ये कनेक्ट करिए तो नहीं चल नहीं connect. Good afternoon, everybody. Yeah. Hello, Dr. Rashmi.
Hello.
Yeah. So we're just setting up the final. This thing will be streaming in another 5 minutes in the website and then on the YouTube. We'll start right away from there. Dr. Raghupati is already there. Dr. Riaz. Hello, sir. Good evening.
Good evening, Anurag. How are you?
Very good, sir. So we'll just be, we are already in YouTube. We'll start streaming from the website in 5 minutes and we'll start right away at 5:45 immediately.
Okay.
Okay.
Good evening.
Hello,
Sir.
Riyaz. Good evening. How are you?
Yes.
Fine, sir.
Okay.
Good evening, Dr. Riaz. Good evening, Dr.
Good evening, Mahesh.
Hi, Anurag.
So we are already live on the website. So we'll be starting in just a couple of minutes. We'll start off with the program right away. We already have, we'll promote people to the panelists.
Hello, Anurag.
Hello, sir. Good evening. How are you?
Good evening. Fine, fine. Absolutely fine.
Hello.
Hello.
Hello, Dr. Vajpayee, you are not audible. Good evening,
Okay.
Dr. Vajpayee.
Yeah, sure. Am I now audible, Dr. Vikas?
Yes.
Okay, sure.
Dr. Bansal sir, namaskar.
नमस्कार सर. नमस्कार.
किसी की आवाज नहीं आ रही है.
तो विकास हमको आपकी आवाज आ रही है. आप अपना वो कनेक्शन चेक कीजिए.
Hello, Dr. Manar. You are muted.
Good afternoon.
Hello, Dr. Manar. Good
Nice to
evening.
meet
How are
all of
you?
you.
Yes, come in.
Yeah, Dr. Bansal.
Hi sir.
Dr. Rajmi, Dr. Rajbi, Dr. Vikas, Dr. Riaz, Dr. Brima, all of you. Nice to see you all in this outstanding meeting. It gave us really a chance to gather all together to discuss endocrinological topics, which is really important for our staff nowadays, especially in the COVID difficulty time, and we cannot attend face to face. So this is actually a good chance from Dr. Bajbi to gather us in this nice meeting.
Thank you, Dr. Manar, for this wonderful word. And we hope that this meeting is going to be quite interactive. And we have got a lot of registrations which have come in from across the world. We have over 400 registrations already, and we hope people join in good numbers. We'll be starting with our inaugural program right away. I think all the people are already there. So I'll invite Dr. Pratik, who will come up and invite for this. This, of course, is the second version of the virtual PPEC. And we are really privileged to have people who have been associated right from the beginning with our program. We've got Dr. Aryan Chaurasia, Dr. Rashmi Kapoor, Dr. Raghupati, who have been always involved with the overall aspects with regards to our PPEC. And we are really lucky to have them again. I'll invite Dr. Pratik to introduce the initial session and to start from there. I hope you're able to see the screen. Yeah.
Thank you, sir. Good evening, everybody. I would like to welcome you all to IPPC, that is the International Practical Pediatric Endocrinology course. This is the first virtual IPPC which is being held. Now, in IPPC, we are focusing more on the practical aspects of pediatric endocrinology. We have divided the course amongst various modules. The course and the various topics will be discussed in the form of case-based studies and question answer through and through, and what we can do, what should have been done, etc. So before, and of course, we have faculty from not only national faculty but from all over the world. We are really looking forward to it. So without any further delay, I would like to introduce our various esteemed guests, and beginning with Dr. Raghupati sir. Sir needs no introduction. He's a professor and HOD in Pediatric Endocrinology in Indira Gandhi Institute of Child Health. Sir, some few words from you.
Greetings of the day for everybody in India and abroad. I would begin by expressing my sincere and heartfelt appreciation for the great enthusiasm and passion with which Anurag is organizing such a continuous feast of webinars, YouTube lectures, MedEClasses, and producing textbooks and so on. It's simply amazing. His efforts are stupendous and simply amazing, as I said. And I envy today's youngsters who are more than fortunate, to have our master of pediatric endocrinology in our midst with his vast experience and knowledge and willingness to share it all, ready as ever. And I'm sure this program today is another in his feather in his cap, and I'm sure it will be a great success. And I wish to consider myself a student, and I always enjoy his lectures, and I will be participating also as one of the delegates. Hearty congratulations, Anurag, for all your efforts once again. Thanks.
Thank you, sir, for the kind words. I would now like to introduce Dr. R.N. Chaurasia, sir. Sir is an extremely senior and respected consultant in pediatrics in Kanpur. And sir is also the patron of the Grow Society that we are so proud of. Sir, some kind words, sir.
Me in this international practical pediatric endocrinal course. I, on my behalf and behalf of the organizing, heartily welcome to all of the delegates. My best wishes and heartily thanks to all the participants from throughout the world. It's my proud privilege to be associated with Grow India since its inception. It's heartening to know that delegates, more than 400 delegates from national and international level, and they are from more than 20 countries, are going to participate in this international practical pediatric endocrinal course. I wish the course a grand success. My heartily congratulations to organizers, especially Dr. Anurag and his team, for organizing this refresher, this course. It's a matter of pride for all of us. Thank you once again.
Thank you very much, sir, for the kind words. I would like to now introduce Dr. Rashmi Kapoor, ma'am. Ma'am is a respected senior consultant in pediatrics in Regency Hospital. She's the HOD of pediatrics in Regency Hospital. Ma'am, from some few words, ma'am.
Thank you, Dr. Pratik. I welcome all of you, all the delegates and all the faculty today for this second international practical pediatric endocrinology course, and really a hearty congratulations to the team endocrinology from our department. Anurag, needless to say that he really packs 48 hours in 24 hours, a very, very hard-working person I've ever met. And he, carries his team so well that it's a treat to see how he conducts himself with the team. And congratulations, all of you, for this wonderful meet. And I hope you will enjoy. And congratulations once again, Dr. Pratik, Dr. Anurag, and all his team. Thank you so much.
Thank you so much, ma'am. Now I would like to call sir for a few words.
Thanks a lot, Dr. Pratik, and thanks a lot, Dr. Raghupati, Dr. Rashmi, Dr. Chaurasia, and the entire faculty. We've in fact got a huge faculty which is there from across the globe that we are seeing, and it is really a pleasure. And all of us have been involved with this hard work in this regard. So I'd like to thank the entire team which has been part of it to make this successful, and also thank all the faculty members who have worked hard towards making this event a success. Special thanks to our inaugural people who have been part of the inaugural session, Professor Raghupati, who is always considered as one of my gurus in pediatric endocrinology, Dr. Rashmi Kapoor, who has always been really encouraging and allowed us to grow as far as endocrinology is concerned in the region, in the state, and entirely across. and Dr. Oren Chaurasia, who has always been a father figure with regards to various academic activities which have been going on. And these all have been involved and responsible for all these events happening in that regard. Now, a practical pediatric endocrinology course is actually something which has been quite close to Grow Society, and we've been doing that for quite some time. We actually started off initially with the programs which were there in terms of the initial workshops, which started way back in 2010. We conducted around workshops across the country. In 2011, we had the first practical pediatric endocrine course, and Dr. Raghupati, Dr. Chaurasia, and Dr. Rashmi Kapoor, all three of them were part of that inaugural program as well. Subsequent to that, we realized that doing programs at the level of individual places, we started doing PPECs across the country, was very labor intense and was very difficult to manage, and a lot of logistic issues. So we thought of using the social media, the YouTube and the Facebook platform to spread knowledge about pediatric endocrinology. And from there, we realized that while videos are going to help out, we need something more concrete in terms of more information which is available. We started with the round fellowship programs, but how many fellows can you accommodate? 2 or 4 in a given time? If you want more people to learn, the best way was to go online. And in 2018, 3 years ago exactly, on this very date, we started MedEClasses, which is a learning platform, and this is really evolved now with multiple other factors happening in the form of books and mobile application to make it much easy in terms of overall aspects. So over the last 11 years or so, we have conducted multiple programs across the country. Over 10 PPECs have been conducted. There have been over approximately 8 modules which have been involved and implemented in around 100 workshops across the country. So a lot of people have interacted and really find friends across the country in that regard, which has been really helpful in that perspective. So as discussed, we started off with our online learning program. And this e-learning started off with a number of videos which are now available over the YouTube. And on last count, there have been 700,000 views from those videos, watch time of around 40,000 hours. So there's a huge amount of pediatric endocrine repository which is available, which is being accessed across the world. But as I discussed, that this is more like a non-systematic way. We therefore went ahead and started with our learning.growsociety.in to provide pediatric endocrine learning using validated tools and practical assessment. And we have got multiple courses. Till now, we are on 24 courses available. We've got special courses for postgraduates and fellows, providing specific needs using animated videos, lectures, and other information. We also conduct bi-weekly grand rounds. So every month we have got one for the postgraduates and one for the fellows. So it's free over Zoom. All of us should join. We already have around 700 people who are regular join these programs. And this is quite helpful from that perspective. As Sir was talking about, we had this basic pediatric endocrinology, and just recently, 3 months ago, we launched our advanced pediatric endocrinology, which is a 2-volume book related to every aspect of pediatric endocrinology. So entire course content is in these 1,000 pages, which are there in these 3 books. So these 1,000 pages, they're all online, as well as now we already made it offline as well, available for people. We always realize that the best way to practice is not really going through books, but to actually go from patient to the book and back. And therefore, we started developing these applications which make life much easier. So rather than going back and reading about DSD, you start off from the patient's point and then use that application approach pathway. So now the endocrinology app is by far the most resourceful endocrinology app on the web and the most downloaded one as well. It has got over 50 pathways, management, approach pathways, analytic tools. And over the next month, we're going to make a massive change in that, adding many new interpreters like puberty, DSD. So if you just put 4 inputs, you will get an output of DSD, output for puberty and obesity. We'll try to showcase how this becomes easy for pediatricians and standard of care would improve subsequently. I'd like to thank, because this would not have been possible without my entire team. So we started off with Dr. Neha and Dr. Chetan as our initial fellows. Dr. Riddhi and Sajali joined subsequently, and Dr. Pratik. Then we have now our current lot of fellows include Dr. Sayan, Dr. Naveen, Dr. Manoj, and Dr. Hemang also has been involved, especially with the DK tool. The tech team with Dr. Shalabji and Prabhaji have been really instrumental in bringing whatever we want to do have been implemented from that perspective. So it's a huge work which is gone. I have immense pleasure in announcing the launch of 2 new courses which we're doing today on the occasion of our 3rd anniversary. That is, one is a fellowship program in pediatric endocrinology. This is a complete 3-year program, which is actually a hybrid program of both on-site and online over 4 weeks of visit, as well as online, as well as a diploma course in pediatric endocrinology for people who have got lesser time. So these programs you can explore over the net. They are available. Now, coming back to this program of International Practical Pediatric Endocrine course, it's in fact really an honor to be part of this program because we now have got really international faculty. On day 1, we have got focusing on office endocrinology, and we have got basically 4 important sessions on growth, thyroid, puberty, and DSD. You've got faculty from across the globe, and we'll be discussing about that very soon from there. In that perspective, we'll be using only case-based discussion. So what we've done is that there will be no didactic discussion. It will all be case-based, and our fellows will be presenting the case to the faculty, and the faculty will be then collaborating and answering on that perspective. The day 2, which is tomorrow on Sunday, is on endocrine emergency starting at 2 p.m. at IST time, and that is a 4-hour program which is there from that perspective. We also had a very wonderful quiz yesterday. Over 100 people participated from across the globe. We'll be announcing the results towards the end of the program today, and we are going to have a final, which is going to be held on the Sunday. The last program would be the quiz, which is going to be very, very interesting in that perspective. So I think without wasting much time, we'll quickly have a look at all the faculty members here. And if they want to have some words on that, Dr. Manar, she's from Egypt. Dr. Manar, we'll love to have your views, brief views on that.
Actually, this is something very marvelous. From India, I didn't expect all these shining stars to give their knowledge and their experience to doctors in different parts of the globe, besides the humbleness from your team and their willingness to just share their knowledge without any hesitation, and they are willing also to participate their experience in no time and without any expenses. Really, I am really thrilled to know all these courses, and one day I definitely look forward to visit India. Dr. Bajbi, you are really an ambassador for your country, not only in terms of your knowledge, but also for your personality and your humbleness. And I always wish you the best for you and your team, and just keep going.
Thanks a lot, Dr. Manar, for those wonderful words. We've got Professor Mahesh Maheshwari, who is in the Department of Pediatrics at AIIMS Bhopal. Dr. Mahesh.
Hi, Dr. Anurag. First of all, it's really a big congratulations to you and your team for organizing this particular event. And I think I can say that I am with you since your journey in pediatrics and then pediatric endocrinology. Seeing you from the post-graduation days to now, I think since then, as a senior resident, I learned a lot from you. And now I think there is a lot of learning I am having with you. And the zeal to work and the enthusiasm you are having to taking the pediatric endocrinology on the highest level, I think it is really remarkable. So I think best of luck to you and your team. So congratulations.
Thank you, Dr. Mahesh. We have got Dr. Rajiv Bansal, senior pediatrician from Jaipur. He is part of our growth session. Dr. Rajiv.
I've been associated with Dr. Anurag since last more than 15 years. And it's such a pleasure seeing you working so hard and coming up with new ideas. I say how crazy you are working to such a great height. I've had the opportunity to train with him under his guidance at his place, and then do a whole year certification course. And then I've been seeing the app he has produced, the type of books he has done, and the enthusiasm he goes around with. I wish all success to him and his team, so that I always ask my students who are doing DNB program, why don't you go and train with Dr. Anurag? Even for 3 months, 6 months, you go, your life will change. It's such a great pleasure to be taught by him. I really admire his way of working. It's a pleasure. Thank you.
Thanks a lot, Dr. Rajiv. We've got Professor Riaz, who is from the Department of Pediatrics at Trivandrum Medical College. Dr. Riaz, a few words from you. You are muted, please unmute. Yeah. Please unmute yourself, Dr. Riaz.
Okay. Thank you for the opportunity, Dr. Anurag. Actually, this is a great activity going on all over the country. We in our department also, our students also attend the program. And in the era of the pandemic, I think education through the social media is gaining momentum. And I am also happy that being a part of it. Thank you. Thank you.
Thank you, Dr. Riaz. Dr. Jyoti is with us. She is from BP Koirala Institute of Medical Sciences, Dharan, Nepal. Dr. Jyoti, a few words from you. You are muted, I think. Yeah. Your voice is not coming, Dr. Jyoti. Maybe you remove that. That will be easier for that for you.
Thank you, sir. Greetings from Nepal. I'm delighted to be part of this IPPE course, and it's always a pleasure learning from you, Anurag sir, and hope to learn and share my knowledge. Thank you, sir.
Thanks a lot, Dr. Jyoti. We have got Dr. Seema Rai, who is a faculty at Faridkot Medical College in Punjab. Dr. Seema, can you please say a few words?
Good evening, sir. I'm quite thrilled, excited. I have no words to explain to be a part of this wonderful program. I have been associated with you, sir, for the past 1 year. And believe me, it has really changed my life. I am feeling more confident in handling endocrinal emergencies as well as OPD case. Thank you so very much, sir. Thank you.
Thank you, Dr. Seema. We've got Dr. Manisha Maurya, who is Associate Professor at at Motilal Nehru Medical College, Prayagraj. Dr. Manisha.
Thank you, sir. It's my pleasure to be working with you and to be the part of this module. And I think you are the best teacher I have known till now. And under your guidance, I hope that most of the people will also will have opportunity to share your knowledge to gain something from you. Thank you very much for giving me opportunity.
Thank you. We've got Dr. Prema, who is head of department at Raj Rajeshwari Medical College, Bangalore in Karnataka. Dr. Prema.
Good evening, sir. Good evening, Dr. Anurag, sir, and good evening, Dr. Raghupati and all the team who is here. I'm extremely happy to be a part of this wonderful team, and I'm associated with Dr. Anurag, sir, and I'm under his guidance, and we are really having a lot of knowledge. The delivery, the mode in which you deliver the lectures has got a lot of knowledge and content, and also the technology and the apps you use is really wonderful, sir. So I think you're doing a great job, and I think many juniors and our postgraduates will be very much benefited by whatever you're doing. So it helps a lot of people to know more about endocrinology, which is a really tough subject. Thank you, sir.
Thank you. We've got Dr. Anurag Katiyar, who is a developmental pediatrician and pediatric, working also in pediatric endocrinology from Lucknow. Dr. Katiyar.
Thank you, sir. So it is a great honor to be a part of this esteemed panel. I still remember I started learning pediatric endocrinology from you when you first visited in 2008 at Era Medical College. And since then, it has been a great journey and great learning from you and your team. Thank you, sir.
Thank you, Dr. Anurag. We've got Dr. Chisholm, who has joined all the way from Nigeria. And she has been one of the most enthusiastic learners from our portal. Dr. Chisholm.
Hello, good afternoon. I'm very sorry for my face not showing. There's a reason for that. But I just want to say that I'm very pleased to be part of this program. I've learned a whole lot. I intend to introduce my colleagues to this, definitely. I want to thank most especially our teacher, our leader, Dr. Anurag. You've been most helpful. I can say for a fact that you're the best teacher I've ever had since my medical school days. So thank you for this experience. Thank you very much.
Thank you, Dr. Chisholm. We've got Dr. Mudita, pediatric endocrinologist at Kurukshetra. Dr. Mudita.
Yeah, good evening, everyone. It's a pleasure to be here and be a part of this module. I would like to thank Sir for this opportunity. And I think Sir has simplified pediatric endocrinology for all of us so much so that, you know, it is helpful on our daily practice, in our daily practice. So thank you, Sir.
Thank you, Dr. We've got Dr. Vikas Mehrotra, our most constant supporter from a long time. Dr. Vikas.
Namaskar, Dr. Anurag. Good evening to Dr. Raghupati sir, Dr. Ashmi ma'am, all the dignitaries and across the globe. Dr. Anurag के बारे में मैं 2 लाइन अगर आज नहीं बोलूँगा तो आज मजा नहीं आएगा. It was in 2010. Dr. Anurag, am I audible?
Yeah, please go ahead. Please go ahead. Yeah.
Hello?
Yeah, you're audible.
So,
yeah.
In 2010, I'm working as in 2010, I was working as a pediatric intensivist, working as a only intensivist only, and I was in constant touch with Dr. Ashmi madam. So I asked her about, madam, can you give me a pediatric endocrinology for a personal reason? And I have got no hesitation to share with this that reason by my son. He was 3 years and 9 months only, and he was type 1 diabetic. In entire MD, all of you agree with me. You see only 1 or 2 cases of pediatric endocrinology. So it was a new chapter for all of us. And Dr. Ashmi said कि विकास को एजेंसी आ जाओ, मेरे पास एक बहुत अच्छा लड़का है एम से, अनुराग. That was my first meeting. So I was with Dr. Anurag with my son, 3 years and 9 months, Shlok. This was in 2010. Then he the way he handled my family, and he inculcate me कि आपको pediatric endocrinology सीखनी है, and this has to be make it accessible to each and every member of every grassroots level of the country. अब आप यकीन मानिए उसके बाद तो जर्नी जो शुरू होती है. आज श्लोक 15 साल के हैं, and Dr. Anurag knows how well he is doing. Apart from that, I was fortunate to have in the first PPE pediatric endocrine practical course, which was held in Kanpur in 2012, I suppose, Dr. Anurag.
Yeah.
उसके बाद से हम लगातार मैंने डॉक्टर अनुराग को उदय होते देखा है एक सूर्य की भांति. और अगर मैं कहूं कि मोदी जी के बाद ये मेरे दूसरे गुरु हैं तो मैं इसमें कोई अतिशयोक्ति नहीं होगी. जो इनको मेरी शुभाशीष है इस बात के लिए है कि जिस तरह इन्होंने पीडियाट्रिक एंडोक्राइन को देश के हर बच्चे के लिए सुलभ बना दिया. दिस इज इम्पोर्टेंट. ऐसा नहीं कि आपको मेट्रो में जाना पड़े, बिकॉज बायोलॉजिकल क्लॉक इज टिकिंग. यू हैव टू एक्ट नाउ. You refer now. So the help of this online training, teaching and accessibility, he made this pediatric endocrinology to accessible to each and every child of the country. And this is a great achievement, Dr. Anurag. I salute and मेरी बहुत बहुत शुभकामनाएं आपके साथ में. और आप गुरु हैं और गुरु रहेंगे, लेकिन हम पीछे खड़े हुए हैं आपके. And I wish कि हर कोई भी बच्चा हमारा देश का pediatric endocrine की किसी वजह से वंचित ना रहे. Dr. Mudita, Dr. Mahesh, everybody is working in their respective areas, and with the true leadership of Dr. Anurag, मेरी बहुत बहुत शुभकामनाएं, and so thankful. God bless you, entire team. Thank you, sir.
Thank you. Thank you, Dr. Vikas. And I think with that, I'd like to thank all the speakers who have come across the world, and Dr. Raghupati, Dr. Rashmi, and Dr. Chaurasia for joining us for this inaugural program. We will right away now start off with our scientific session. And our first session would be on growth. So as we've discussed earlier, we are going to talk only regarding practical aspect and case-based discussion, not much theoretical discussion on that perspective. So we'll start with the first session on growth. And this session basically is, of course, the fundamental of every aspect of pediatric endocrinology. For this session, we've got Dr. Mahesh Maheshwari, Dr. Anurag Tatia, Dr. Bansal, who has already been introduced. And we've got Dr. Riddhi Patel, who is one of our fellows from Regency CDR, one of the most hardworking and the most accomplished person, and who has done a lot of work in pediatric endocrinology. And it is often difficult to do original work. She actually created from scratch a bone age application, and she'll be talking about that. I will also be joined by my student, Dr. Sayan, who will be moderating the session. Before we start with the cases, just a basic aspect which we have to just look at regards to growth failure. So growth failure, as discussed, is a common problem. 2.5% of all children have growth failure. 80% of them are physiological, 20% have a disorder, and that's where the catch is. Which children are physiological, do not require evaluation, which children have a disorder, and that's what we're going to do over the next 45 minutes or so. And this is something which you can all go and have a look at it. This is in the recent journal of Indian Journal of Pediatrics. Riddhi and myself have published. This talks about the overall approach and how we can simplify evaluation of growth failure. Now, when we talk about short stature, 80% is physiological, CDGP or familial, 20% is pathological. So the first question is it really short stature? The second is it physiological or pathological? Then the question is it primary or secondary? Whether it's nutritional or endocrine. If you answer these 4 questions by the end of this session, our job is done. That's what we're going to do over the next 40 minutes or so. Now, the first question, of course, is whom should we evaluate? And this is from our paper, which is going to come up very recently in Journal of Pediatric Endocrinology on 900 children. What we found that as the height standard deviation score goes down, the chances of pathology increases. So above -2 SDS, only 1 in 40 will have a pathology. If you go between -2 to -3, it becomes 1 in 2. And when you talk about less than -3, it means 80% becomes a pathological cause. So what it means, the worse the growth failure, the more likelihood of pathology. So that's why we've got this traffic light approach. If you have a height more than -2 SDS, wait and watch. -2 to -3, maybe you have to evaluate after some time. Less than -3 is an emergency. You have to stop and take in terms of that. So when you talk about growth failure, children who are really short would require evaluation at all point of time. Children who are short and not growing, height below -2 to -3 SDS, not growing over the next 6 months or a year, will require evaluation. And of course, if you have a child in the normal range also, but who is faltering, you also require immediate evaluation. So short and not growing at all will require evaluation from that regards. And 3 things we'll focus upon are the growth chart, puberty, which of course we'll discuss on the pubertal aspect, and the bone age. So I'll hand over the proceedings to Dr. Sayan, who will start off with the session with the first case. Yeah. And this is more like a sort of a ward round going on, or a clinic going on, in which Dr. Sayan is presenting the cases to our faculty.
So a 12-year-old girl presented to us with concerns of short stature. Her height was 132 centimeters. She has a weight of 28 kg. Her father was 164 centimeters, while her mother was 151 centimeters. So Mahesh sir, kindly tell us whether this child is actually short.
Okay. Thank you, Sayan and Dr. Anurag, for giving this opportunity. Before going further on this particular case, I think we should be aware about the growth charts, which growth chart should be used, and what we are going to get from these growth charts. So when we plot this particular height of this girl on the growth chart, we are going to get the absolute status in the form of centiles, and at the same time in the form of height SDS. So that will give the comparison with the population. We should also get the findings that what is the parental expectation from these growth charts. So we should take out the target height, and the target height is usually taken up by calculating by adding mother's height and the father's height divided by 2, and then we should get the target height standard deviation score. Nowadays we can use the corrected standard deviation score, that is height SDS minus target height SDS will give you the parental expectation related to the height. And the third important thing that we can get from the growth charts is the effect of nutrition. So if there isn't weight is more affected or height is more affected, that will give us an idea that if the weight is more affected, we also get the idea related to this particular nutritional status on the BMI SDS. On this basis, we will get if height is more affected, then probably we are dealing with the endocrinological cause. If we are dealing with the weight is more affected, then we are dealing with the nutritional cause. So when we see this particular chart, so the first thing is we should use the IAP growth charts up to the age of 18 years published in 2015. So when we plot the growth chart, we've seen that when we take out the target height by adding this mother's height and the father's height, so this will come round about 154 centimeters.
151.
Yeah, it's 151 centimeters. So there will be a target height. So we will plot this target height on the 18 years of age at the growth chart. And then we will take out the plus 6 centimeters and minus 6 centimeters, by which we can take out the target height range. When we draw this particular graph, revert back, and at the time we've seen that this height of this particular girl, as such, this is less than 3rd centile. But when we calculated this particular thing, we've seen that this is following the parental norms, parental expectations. The next step is that I already told you to take out the weight for height and height for age. So when we take on the height for age is the height for of that particular age is the 50th centile. So when we take on, so in this particular girl, the height age is 9 years and the weight age of this girl is also 9 years. So it's almost the same. So this we can say that this girl is following a particular path expected to the parental expectation. So this girl is belonging to a familial short stature, and when we take out the corrected height SDS score, if it is more than -1.5, that suggests probably this child is belonging to familial structure. The Medscape E application is having a growth interpreter. We just put these data on those particular parameter, and we will get idea that where this child is fitting, and that will lead us to the familial short stature. Once we label this child as a familial short stature, we don't need any investigations per se for this particular girl.
So thank you for your explanation. So we can diagnose this child as a case of familial short stature according to this point of time. But sir, how do we know that the child will not falter when he comes back to us after 6 months?
Okay, so that is an important thing. The next thing is, so this is a familial short stature. We just need to give the reassurance. And the most important thing we need to do the serial monitoring or the growth velocity we should see. So we followed up this child for 6 months and height reaches to 135.5 centimeter. So you can say there is a 6 month, the height gain is 3.5 centimeters. In a year, it is 7 centimeter. When we plotted this particular thing in the height velocity chart, you can see this girl's 135.5 centimeter is coming at the exactly, if you see this particular point, this point is showing that this child is exactly 50th centile. So it is not faltering below 25th centile. So most probably this child is doing well as per the expected parental expectation.
Yes, sir.
Yes. So I think that's a very, very important point which Dr. Mahesh talked about for correcting for the family. That becomes absolutely important. Now, if we look at this graph from here, this perspective, we have developed a growth interpreter with just input of these parameters. You will directly get not only the outputs, but also the interpretation. So whatever Dr. Mahesh said was clearly the familiar short stature, and this is what the outputs will also come from that perspective. Now, just to see what happened to this girl, what happened, Sayan, later on?
So when the child was followed up, her growth velocity was 7 centimeter per year for the next 6 months. And this was when this was plotted on the height velocity growth charts, it was at the 50th percentile. So as Dr. Mahesh just mentioned, this child is doing pretty well, and she's a case of a familial short stature.
So Dr. Mahesh, what will be the key practice points for us from here?
So it is very important to take out the target height and the corrected SDS. So correct the height for the parental expectation, and at the same time, there is no workup is required. The child is falling within the target range, and at the same time, so there is no workup if height is within the target range.
And follow-up
is very important. Follow-up is very important in the mild growth farewell, and the growth velocity is very crucial in following up this child in the subsequent years to come.
Thank you so much, sir. So now we move on to the next case. This was a case of a 13-year-old boy who again presented to us with concerns of short stature. His height this time was 135 centimeters, weight was 30 kgs. His father had a height of 169 centimeter and his mother had a height of 156 centimeter. So Dr. Anurag, is this actually short stature, and how can we move forward in this case?
Thank you, Dr. Sayan. As Dr. Mahesh has already told, we will plot the parameters on a growth chart, the IEP growth chart. And when we plotted, we found out that the height age of this child comes out to be 9.5 years. And the weight age is also 9.5 years. And the mid-parental height comes out to be 169 centimeter. And one more thing, the bone age is at 11 years. So we can clearly see that this child is short for the population also and for as per his family norms also. Dr. Sayan, any other investigations were ordered?
Yeah, actually this child came from, was referred to us and already a lot of workup has been done. So Dr. Sayan, you can highlight on that.
Sir, as far as the screening investigations was concerned, all the screening investigations were normal. but the child was referred to us with a basal growth hormone of 0.1 picograms per ml. So is this a case of growth hormone deficiency, sir?
Now I think we should come back to our growth chart. And I think there are 2 or 3 factors which were missed while on the growth chart. First was the testicular size was 3 centimeter, which means that the child has not yet entered into the puberty. And another thing, the bone age was done, which comes out to be 11 years. And when we consider his height as per his bone age, then it comes out to be within the target height range. And also we can clearly see that the both height and weight age are equally affected. And now coming up to the growth hormone levels, I don't think that it was really needed in this child. And also if it is done, then the stimulation test has to be done, and that to be after proper priming, as this child is a peripubertal, in the peripubertal age. So
that is a very, very important message, Dr. Anurag, because this child actually had got a growth hormone stimulation done, but as you very rightly mentioned, was unprimed. So that's a big, big problem that we are seeing in this case. So on prime, this thing, Dr. Anurag has suggested we should do a prime sample. So what happened, Science?
So on priming, the peak GH was 15.2. So what are your thoughts on this, Dr. Anurag?
So it is to be remembered that for any girl who is above 8 years of age and or a boy who is above 10 years of age, a growth hormone assessment is to be done only after priming, either with a ethinyl estradiol or with a testosterone. So, and when we followed up this child, the growth velocity picked up and it landed up to be within the normal range.
So I think this is one of the most important things to remember, that if you have a short child just around puberty who is just below the chart, it is unlikely to be GHT, most likely constitutional delay of puberty and growth. The problem is basal growth hormone is useless, and then Dr. Anurag has already said that unless you do a stimulation after priming, you will get a wrong result. So what could be the clinical parameters? Now, this is our study which shows that height standard deviation for bone age is the best marker for constitutional delay of puberty and growth. So if your height is short for the age but normal for the bone age, it's basically, this is what height STS for BA tells you. If your height standard deviation for bone age is more than -2, it is usually constitutional delay of puberty and growth, as was seen in this case that we observed in that perspective. So Dr. Anurag, what are your take-home messages from this case?
Well, the bone age and the puberty assessment is very crucial in all the children with for growth assessment. And we should consider constitutional delay in peripubertal children. And growth hormone workup is rarely needed and is to be done in only in the cases with substantial growth delay, and priming is essential before growth hormone stimulation test.
Thank you.
Thank you so much, sir. Coming on to the third case, this was a 15-year-old girl with a 15-month-old girl with a birth weight of 4,000 grams. So large for the gestational age, but with short parents having a mid-parental height of 150 centimeter. Now, this child was meticulously followed up on a growth chart and was found to have faltering. So the failure to thrive caused the diagnosis of RTA in this case. Now, this is the plot on the growth chart that you see. The child was faltering from the initial phase at birth. The child had normal renal function tests, liver function tests, and normal CBC. Had mild metabolic acidosis, was diagnosed as a case of RTA therefore, and given sodium bicarbonate.
So Dr. Rajiv, do you consider this child to be RTA?
No, we need to, no, this is very important because this child was born 4 kgs and the mid-parental height is 150 centimeters. So we need to plot it on the chart, and then we see where the child initially started with and where the child is faltering and trying to reach the final height, or is trying to follow the graph pattern too. So if with the normal renal function, the LFT, CBC, and if we also do a potassium levels, then we'll probably come to a realization. And then if we take a detailed history, did the mother suffer from diabetes when she was pregnant? Well, give us a clue as to, was this child in front of a diabetic mother? with an environment which is responsible for this kind of a situation where the child grew faster at in the mother's womb, and then is trying to take the genetics part of its story. So ultimately, the growth will falter and the child will then try and follow a pattern which she was where she was trying to follow as per her growth potential.
So this is clearly a typical cash down growth. Very nicely said by Dr.
Cash down growth.
Yeah. So we know that the size at birth is determined by the environment, while the size at final height is determined by genetics. So this switch happens by 2 years. So in 2 years, you may go up or go down. This is going down, nothing to worry. Do not worry. We'll talk about another case of going up of SG and catching up. So this is a classical common situation. So this is infantodiabetic mother and cash down growth. So the messages we get, Dr. Rajiv, from this case are?
The size of the size at birth is determined by the environment in which the baby is in the mother's womb. Secondly, the adult height is determined by the genetics. So if the genetics is, as far as mid-parental height is concerned, is on the lower side, you'll ultimately follow that pattern and you need not to get worried. Thirdly, as what Dr. Anurag said, the switch occurs at around by 2 years of age. So we have to follow the pattern even before and after that, so that we know exactly where we are leading to. And no workup as such is needed if the things are as are per the parental height of that particular child.
Thank you.
As far as transition is concerned.
Thank you so much, sir. Coming on to the next case, this was of a 10-year-old girl with a height of 120 centimeters and a weight of 15 kgs only, was diagnosed as a case of growth hormone deficiency. So Dr. Riddhi, do you agree with the diagnosis?
So Riddhi, this is the growth chart.
Thank you, Dr. Sain. So this growth chart showing that weight age is around 5 years and height age is around 7 years. So this is clear-cut nutritional pattern of short stature. So this screening investigation done in this child, which is normal, TSH is normal, even TTG is also normal, and IGF-1, which is lower for the age, that is 120, and further investigation done, which are basal growth hormone, which is 0.5. So based on this low IGF-1 and low basal growth hormone, child was given diagnosis of growth hormone deficiency. But as beautifully explained by Dr. Anurag in previous slide, that no role of basal growth hormone in diagnosing growth hormone deficiency, which we will discuss in subsequent slides. So bone age is also important screening investigation in this child while approaching every case of
bone age by far is the most important and confusing tool, and we often get results which are very weird from age 5 to 18 years, and we've got fracture and rickets, and those sort of results are there. So how can a pediatrician, Dr. Riddhi, easily assess bone age, and maybe in 2 minutes, how can you explain somebody to get a bone age done? Is it even possible, or have you made it possible? We wanted to know about that on that regards. Yes.
Yeah. So before ordering bone age, always keep some points in mind that always write prescription at X-ray left hand and wrist, including fingers. Otherwise, you will get X-ray like this, and there is no value in assessing bone age of this X-ray. Fingers should be fully spread. It should not be close to each other, and the X-ray should be properly exposed. It should not be overexposed or underexposed. Otherwise, you will not get any morphological criteria of smaller bones. So
the other question, Dr. Riddhi, is that which bones to look at in undergraduate, in post-graduation? Most people say count the carpal bones and subtract by 1, you will get the bone age. Some people say look at radius and ulna. Which bones are really important in terms of bone age assessment?
So smaller bones like carpal bones and appearance of the epiphysis in the smaller phalanges are important in less than 3 years in boys and 2 years in girls. But after the infantile and toddler age, there is no role of the carpal bones in assessing bone age. And the importance of bone age assessment comes only after 3 years of age. So in pre-pubertal and pubertal years, always look for the epiphysis, that is smaller epiphysis in phalanges. Look for the size of epiphysis, shape of the epiphysis. If the size of epiphysis is smaller as compared to metaphysis, the age is around less than 4 years. If it is slightly bigger, Then it is around 4 to 6 years, and in 6 to 8 years it becomes equal to metaphysis, and after 8 years it begin to grow wider than the metaphysis. After that, the caping is started, and then fusion becomes in the pubertal years. So always look for the different areas in different ages. We should keep this slide in mind, but it is not easy to apply this in routine pediatric practice, and it is very difficult to remember also.
Yeah, every time I've done a workshop of around an hour or 2 hours, also bone age, everybody says that I understand now, but when I go back to my clinic, I just forget everything. So what can be done in this setting?
So though routine Tenno-Whitehouse 3 and Grulich pile method is available, but it is very difficult and cumbersome to apply in routine pediatric practice. So we have developed this bone age application for easy bone age estimation in routine pediatric practice. Though this slide looks very complex, but don't worry, the application is very easy. This slide gives idea about the development and validation of the bone age application. So it is developed from 307 radiographs. We have first rated each and every site of the Tenno-Whitehouse 3, that is 13 different sites by 3 expert users, and then these were compared with a standard method of Tenno-Whitehouse 3 in another 90 radiograph, and best region of interest were selected based on regression analysis. After that, they were loaded on mobile application and validated against the gold standard method in another 200 radiograph by 2 expert user using the various statistical parameter. And it is also compared with the bone expert and Tenno-Whitehouse 3 by both expert and non-expert user, which are not using bone age estimation in routine pediatric practice. And we found that this method is as precise and as accurate as Tenno-Whitehouse 3 method, and it is also comparable with bone expert. So we can easily apply this method with lesser time of assessment in pediatric practice. So can we have next slide?
How does it work, Dr. Riddhi? Yeah.
So we have to just focus on only 5 sites, that is middle phalangeal and proximal phalangeal epiphysis of middle finger, proximal phalangeal epiphysis of thumb, radial and ulnar epiphysis, and we have to enter only 2 input parameters, that is gender and date of birth, and then select the image which is closest to the patient's radiograph, and only look for the parameters like size of epiphysis, shape, appearance of white line, and how the caping started, what is the fusion. And when we press select every 5 images and then press calculate button, we will get the bone age, also the range of the bone age. So this method is as precise as Tenno-Whitehouse 3, and this is easy to apply in routine pediatric practice. So please try to apply this method using the MedEClasses.
Really made looking bone age as easy as making Maggi noodles. Within 2 minutes, you can do that. This study has been done, and she has actually won 2 awards for this novel application, which is there. It's under publication currently. So I think big round of applause for Dr. Riddhi and Dr. Chetan, Dr. Saidi, who are part of this team to really develop such a wonderful tool for the pediatricians. Within 2 minutes, you can get the answer from that. Now let's go back to the case, Dr. Riddhi. Why do you think this child having a nutritional cause was diagnosed as growth hormone deficiency? What are the problems in growth hormone assessment?
First of all, the IGF-1 was done in this child, which is the screening investigation for growth hormone deficiency. But there are some caveats in doing the IGF-1. IGF-1 is an age-dependent parameter, which is clearly shown in this graph that below 5 years, there is no role of doing IGF-1, which has no value in differentiating the growth hormone deficient patient and normal patient. Secondly, IGF-1 is also dependent on nutritional part. So this child was malnourished. Weightage of the child was very low as compared to height age. So IGF-1 was waste of money investigation in this child. Secondly, growth hormone, basal growth hormone was done in this child, which was totally waste of money, because growth hormone has got growth hormone is pulsatile hormone, is that got diurnal variation also, and its level is also affected by the meal. So there is no role of doing basal growth hormone in diagnosing growth hormone deficiency. Always do growth hormone stimulation test, and that should also be done under priming in peripubertal years. Otherwise, you will get false diagnosis of growth hormone deficiency. So coming back to the case.
Yeah, thank you so much for the explanation, Dr. Riddhi. Now, the workup showed that the IgA was undetectable in this case.
Okay, so this suggests the diagnosis of celiac disease, even though TTG was normal, and the diagnosis was confirmed by duodenal biopsy, suggesting the complete villus atrophy. So always think of nutritional and treatable causes of short stature before jumping to the endocrine causes of short stature. And when we started gluten-free diet in this child, there was dramatic improvement in oxological parameter of height and weight. So learning point.
Yeah, kindly give us
From
the
this case are
so clearly.
So learning points from this case are that always consider nutritional cause of short stature when weightage is affected more as compared to height age. Consider IgA in each and every suspected cases of celiac disease, because some of the cases of celiac disease have IgA deficiency, and we can falsely not diagnose this celiac because by doing TTG, that is screening investigation, children and children less than 5 years of age. And
and there's no role of basal
growth hormone in diagnosing growth hormone deficiency.
So I think the big message which came out of from these cases that the most important thing to look at in a short child is the weight, not the height. If you have a short and thin child, it is nutritional. If you have a short and plump, it's endocrine. I think that will carry forward in the next case as well, Dr. Sayan.
Yeah, just the opposite case to the child that we just saw. This was an 8-year-old boy with a height of 100 centimeters only, had a weight of 18 kgs, was diagnosed as a case of celiac disease. Dr. Mahesh sir, do you agree with the diagnosis?
Thank you, Dr. Sayan. Can you just show me the growth chart before accepting that this is a short child? Okay. So if you can see in this particular growth chart, this child's height is definitely falling less than 3rd centile. So that child definitely requires evaluation as per the parental expectation, if you can see. And when we plotted the height age and the weight age, and I think if you see this particular chart, growth chart, then you can see the height age of this child is 4 years and the weight age of this child is 6 years. So definitely his height age is more affected than the weight age. Can you show me the other investigations also on which basis this child is made?
The diagnosis was primarily made because of a TTG which was 32, and the child was referred to us with the diagnosis of celiac disease.
Yeah,
there was no biopsy done. Most importantly, no biopsy was done.
Yeah, so that was my next question. That if the TTG is 32, that is definitely on a higher side, and just like Riddhi says, there is no role of basal hormone. So doing growth hormone as a single value probably not meaning much. So this TTG was definitely on a higher side, but definitely this is not the gold standard to make the diagnosis of celiac disease. So is the duodenal biopsy done in this particular child, Dr. Sayan?
The duodenal biopsy was not done on referral, but the child was referred mainly because there was no effect on the height of a gluten-free diet.
Okay, so that is also one of the indicators that probably this child is not actually in the, so there are few indicators till now what we are getting, that this child's height age is more affected than the bone age. That is against the nutritional cause. In nutritional causes like celiac disease, usually the weight for age is more affected than the height age. And this is the reason, and you can see in this particular slide, in nutritional cases, the weight for age is more affected than the height for age. And in contrast perspective, in endocrine causes, there will be more height for age is more affected than weight for age. So this is happening in the similar in our child. So this child definitely need a confirmation by doing an duodenal biopsy. But till now, this looks like to be an hormonal cause or endocrine cause. So when you plan a workup, so duodenal biopsy and this child is normal or
so we did so we did a duodenal biopsy in this case, and it turned out to be normal, sir.
Okay, so definitely the duodenal biopsy is normal, and we had a basal growth hormone level available with a low volume. So probably this child is an endocrine cause and a level is available, but we should not confirm the diagnosis of growth hormone deficiency until unless we will do the growth hormone stimulation test. So when we
after a normal biopsy, so we did go ahead with a growth hormone stimulation test, and a peak growth hormone levels of 1 was found in this case, sir.
So this is definitely very low. So this is definitely very low on the peak side. So this is suggesting that this child is having not a celiac disease. This child is having a growth hormone deficiency, that is an endocrine disorder. And any child whom you diagnose a growth hormone deficiency, the MRI head is most important investigation to find out any pituitary, hypoplastic pituitary. So that is an important thing that you need to be aware in that particular child.
The MRI showed a hypoplastic pituitary, sir. So what to make out of this MRI, sir?
So this child is definitely having a growth hormone deficiency in this particular child, and that is confirmed by doing the growth hormone stimulation test.
So just Dr. Mahesh, how do you approach a child like this case had a TTG level which was within 10 times the normal range? So what do you think should have been done? If you go by this SPEGAN criteria, what do you suggest what should have been done in this case?
Okay, so in this case, I think there are multiple criteria that say probably this is an endocrine cause. One thing is the height for age and the weight for age. Second thing is that duodenal biopsy is normal in this particular child. So we get in our practice a lot of times there may be, and when we do the IGA, this may be negative. There may be a 1 to 10 times of the upper limit. So the biopsy is indicated in those children. If the above 10 times upper limit, then EMA antibody can also be done. And on the basis of this, because the child is having almost 30, so this is definitely more than 2 to 3 times of the expected normal. So you do the duodenal endoscopy and biopsy. If the Marsh criteria, if there is a 0 or 1 on the histology, then celiac is excluded in this particular child. If there is a criteria of grade 3 and grade 2 and grade 3 onward above, then it is a suspecting of celiac disease. And if the TTG IgA is more than 10 times and EMA antibody is also positive, you can confirm that this is a celiac disease. If this is a negative, then you can go for the biopsy.
I think the most important message which comes from this case is the pre-test probability. Now, if you look at a child who is short and plump, having a celiac disease pre-test probability is very low. In that setting, just because the TTG is widely elevated doesn't make any sense. You have to go for biopsy. If, on the other hand, you had a child like the case which Riddhi discussed and TTG was more than 200, maybe you could have missed the biopsy, but there's no point not doing biopsy in this case. So again, this is what we try to do to differentiate nutritional from endocrine cause. And what we found was that BMI SGS was the best marker to differentiate nutritional from endocrine. But the key message even there is that you will miss celiac disease if you do only in everybody who is lean. So TTG should be done right across the spectrum, but you have to interpret TTG properly. That's very important. And if it's less than 10 times, do a biopsy. That's a big message in that regard. So I think the practice points, Dr. Mahesh, from this ones are.
So I think you very rightly said that always think an endocrine cause when you are seeing a child who is short and plump. And the second is biopsy is always mandatory to diagnose the celiac disease. And MRI is an essential investigation in children where you diagnose a child as a growth hormone deficiency.
Thank you. Next case.
Thank you so much, sir. So this was a 6-year-old boy with a height of 90 centimeters. So very short, had a weight of 12 kgs, was diagnosed as a case of nutritional rickets, received multiple doses of vitamin D, but still the X-ray was suggestive of rickets. His calcium was 9.2. His ALP was also normal, but a potassium which was done revealed the potassium level of 3.2. So what do you think, Dr. Anurag, of this case?
So we can clearly see it is a case of rickets with growth failure, and cause could be nutritional or malabsorption or renal failure or RDA. So we will first proceed with the therapeutic trial of vitamin D and the calcium in all these children. And as in this child, we have already given the vitamin D and calcium in proper doses, still it is not responding. Then we will look for the phosphorus levels and also the potassium level. And the potassium level in this case is on the lower side.
Potassium
and the phosphorus
was 3.2?
Yeah.
Yes, sir.
And the phosphorus is within normal. So
yes,
we will order a blood gases in this child.
Yes, sir. Blood gas was done and it showed a pH of 7.1 with a base excess of -15 in this case.
So this is a clear case of renal tubular acidosis. And
so the urine pH was also 6.8 in this case.
Yeah. We will look for the urinary pH to differentiate whether it is proximal or the distal RDA.
Yes, sir.
We can clearly see that there is. Yeah.
Yes,
we can clearly see that there is a metabolic acidosis along with the alkaline urine. So it is a case of distal RTA. And
Thank
we
you
have
so
to do a ultrasonography which shows this
Yes, sir.
calcifications.
Yes. So what are the take-home messages, sir, in this case?
So we should think of renal tubular acidosis in all children with rickets and along with the growth failure. And low potassium is an important clue in this case. And blood gas and urinary pH is diagnostic for RTA.
Thank you so much, sir. Coming on to the next case, this was a 14-year-old girl with a height of 120 centimeters. She had a weight of 32 kgs, and this is how she looked on examination. She had normal screening tests. Now, Dr. Rajiv, how do we move forward in this case, sir?
You have to see this girl who is 14 years, short stature. You see the slight webbing of neck, which you can appreciate from the picture you have provided. In fact, I saw a case back only, and she has got wide nipples placed widely. So with normal CBC, LFT, RFT, and thyroid function and PTG, so we'll have to go into and see what things work. We have. Can you show me some more features so that we can explain and maybe have some idea to what the clinic does? Like if you see,
Hello, sir.
I think there's some problem there. So this is a girl whom we can see very clearly classical features which are there. Yeah, Dr. Rajiv. Yeah. Dr. Rajiv,
so you can see the short fourth metacarpal bone in this child.
Yes, sir.
And hello. Can you hear me?
Yes, sir. Yes,
please
sir.
Go ahead. Yeah.
Am I audible?
Yes, sir. You are audible.
Yeah. And the other features, then the FSH may be high because initially in these children, this child has got, to my mind, Turner syndrome. They can be high FSH to begin with, and then once we follow up, and then we'll be able to see that this child has the cystic may have features like cystic hygroma, may have kidney issues, and all kinds of features which will suggest that this child has got the cardiac abnormalities may be there associated with it. So we have to do a karyotype on this child for a clearer picture, because then only we'll be able to confirm the diagnosis in this particular
one
patient.
Question which is often asked by me is that this girl looks like Turner's. Everybody knows if you're walking, maybe you can have she might be the second object visible from the space. Like they say, China, Great Wall of China is visible. If you have a girl walking like this looks like Turner syndrome. FSH is 72. Why are you wasting money in doing a karyotype? That is what the pediatricians ask me. So how do you define doing a karyotype in this girl? Like this is very classical Turner's.
Because they ultimately land up, they have got congenital dysgenesis also. Ultimately what happens is over a period of time, there will be ovarian failure in these children, and this could be an indicator. So unless you do a karyotype, you will not probably be able to finally make a final diagnosis.
Very important message with Dr. Rajiv is saying that even if you know that this girl is Turner's, you have to do a karyotype because you know of gonadogenosis, Y cell line, risk of carcinoma. Those points become very, very important. So you have to do karyotype in everybody in that regard. So what are the key points, Dr. Rajiv, from there?
So we have to consider in all children, on all girls, even if they don't have full features, to consider Turner syndrome, especially in girls who are short stature. So karyotype is mandatory in all these patients, and we should also screen for other associations in these patients. They can also have diabetes, and they can have celiacs may be associated with them. And there is no need for growth hormone stimulation unless we plan treatment, because all those parents who are willing for treatment, then we go for growth hormone stimulation, find out exact levels, and then we give them because we need not to miss that window time where the growth hormone can be beneficial to these patients.
I think two big messages which Dr. Rajiv is giving out here is that one, karyotype is absolutely mandatory, and growth hormone levels we may do stimulation, but even if they are normal, we may still consider treatment. These are the two big messages coming out from this case. Yeah, Dr. Sain, carry on.
Thank you so much, sir, for taking us through this case. Now, coming on to the next case, this was a 5-year-old boy with a birth weight of only 2.1 kilograms. He complained of, his parents complained of him having poor growth, but had normal development. So at 5 years of age, this child presented to us with a height of only 90 centimeters and a weight of only 10 kilograms.
So Dr. Riddhi, what do you think of this child who is having such a short height that we are seeing? And one key thing that you have looked on is the birth weight.
So this boy born with the low birth weight of 2.1 kg, and his mother was complaining that child is always on the lower side, poor growth, and child has normal development, no dysmorphism, and we have ruled out the screening the nutritional and treatable causes of the short stature. So this child required growth hormone therapy without doing growth hormone stimulation test, because this child will never grow again. This will remain always on the lower side, because if so, growth in the SG is like double-edged sword.
What we have heard, yeah. So just before that, what we have heard is that a lot of children with SGA have metabolic syndrome and they develop problems. So why are you giving growth hormone which can cause worsening of metabolic syndrome?
So growth in the SG is like double-edged sword. If they are slow growers, they will grow slowly, they will hit the puberty early, and they end up with the short adult, but they are healthy. They will not develop metabolic complication. But in another group of individuals which show rapid catch-up growth, they tend to gain more weight during pubertal years, become overweight and obese, and then they become tall adult, but they develop metabolic complication like type 2 diabetes and dyslipidemia. So they need the early screening for metabolic parameters. So this graph clearly showed that whatever catch-up growth occurs, that occurs by 2 to 4 years of age. After that, the growth will, the child will not grow further. So if the child is not growing by 4 years of age, we should start growth hormone therapy without doing growth hormone stimulation test, because they have intrinsic growth hormone resistance phenomenon. So they will need growth hormone for the.
I think the big message which came from this case and Dr. Riddhi was that this child is short. He will enter puberty early. If you don't intervene, he's going to land up short. That's very, very clear. Very important. If your child is not catching by 2 to 4 years, think of GH. So I think that's what the key practice points, Dr. Riddhi, from there.
So monitor growth in child with SGA always, because if they are slow growers, they need growth hormone therapy. If they are rapid growers, they need early screening for metabolic parameters. If there is no catch-up growth by 2 to 4 years of age, start growth hormone therapy. Assess the treatable causes of the short stature and rule out that. After that, start growth hormone therapy. And there is no need for growth hormone stimulation test in this case for starting growth hormone therapy.
So I think we're not discussing too much about diagnostics here, but regarding growth hormone, many points have come in. 1, don't do a basal growth hormone. 2, do a primed growth hormone in a peripubertal child who is short. And 3, do not waste your money in doing a growth hormone stimulation in Turner's or SGA, in which there are other indications of growth hormone therapy.
So coming on to the next case, this was a 10-year-old girl with a height of 112 centimeters, weight of 24 kg. Now his mother complained that the child is not growing at all. He had a normal screening investigations. So Dr. Mahesh, are we missing something in this case?
Thank you, Dr. Sayan. I think if you see this particular child's this pictorial photograph, then this child is definitely short, looks by the age of 10 years. If you see that there is an definitely an upper limbs and lower limbs are looking little shorter, and apparently there is an upper segment and lower segment disproportionation is there. So the anthropometry is definitely going to play a very important part in this particular child. So when you do probably the upper segment and lower segment ratio, it is 1.5:1. So at the age of 10 years, what we expect that upper segment, lower segment ratio should be 1:1. So in this side, definitely there is an upper segment, lower segment is not suggestive of that normal growth. So this is probably a case of skeletal dysplasia, hypochondrodysplasia. In case if you really want to work up further, we can go for the mutation studies. That is the FGFR receptor mutation studies that can be planned in this particular child. Sometimes these children can present just like a rickets. So that also needs to be ruled it out.
Very important. Rickets and large head. Often they will diagnose as hydrocephalus. I have seen children presenting at 1 year of age. People say hydrocephalus, but they are actually achondroplasia. That's a big message there. The practice points clearly that body proportions, Dr. Mahesh, are very important.
Yeah, so that is very important. Then every child, whenever you thinking about a short stature, the body proportion measurement is very important. Hypochondroplasia sometimes resemble rickets, so you need to be very careful when you are thinking about that. There is no need for extensive testing just for the growth hormone, finding out the growth hormone deficiency. Genetic test is definitely important for the prenatal diagnosis in this particular child.
Thank you so much, sir, for again re-emphasizing for us students the importance of proper anthropometry. So coming on to the next case, this was a 7-year-old boy with growth failure. He had a height of 102 centimeters and a weight of 16 kgs. Now was referred to us with doll-like faces and a low growth hormone level and a low IGF-1 level. Now, when this child came to us, he had a firm hepatomegaly of 10 centimeters with a high SGPT. So, Dr. Anurag, is this a case of growth hormone deficiency?
Yeah, now this child is, although there is substantial growth failure and doll-like faces, along with a low growth hormone level and low IGF level. But what was missed on systemic examination was a huge hepatomegaly, and it has a raised SGPT level. So we all know that impaired liver function test results in low IGF-1 levels also. And this is most likely a case of glycogen storage disorder. And generally, the blood sugars are on lower side, and on induced fasting, it resulted in ketotic hypoglycemia. And when we follow the flow chart for ketotic hypoglycemia, the lactate levels were done. The lactate levels come out to be normal. Normal lactate with the organomegaly, it most probably diagnoses GST type 3, 6, or 9. And
I think very important message there, that always think of systemic causes. Do not rush for an immediate workup. And if we had done a liver, check for the liver, we would not have done all those investigations very clearly. So, Doctor, what are the key points, Dr. Anurag?
Don't rush for growth hormone workup in all cases of growth failure and doll-like faces. Systemic examination is very crucial, and organomegaly suggests GSD. And although a systemic examination is to be and a thorough systemic examination is to be done before the endocrinal workup.
Thank you so much, sir.
So just to summarize the approach that we'll be discussing about, this has been published just in Indian Journal of Pediatrics. We have tried to develop a very simplified pathway for evaluation of growth failure, which looks mainly on clinical parameters and then uses investigations much less. And if we just look at our application, it uses these parameters. So we start off with how short the child is. Is the child short for the family or not? Is the child short for the bone age? So the child is not short, no evaluation. Child is not short for family, no evaluation, familiar short stature. Child is not short for bone age. It is constitutional delay of puberty. And only then you start workup, and that becomes important right from clinical examination, clinical clues. And then you do the basic screening workup. And then based upon that, you work up whether you need a TTG and an IGA. We recommend TTG for everybody, IGA and fecal calprotectin for children who are having nutritional pattern of growth failure, and GH at the end. And we are doing a lot of cost-effective studies, and we find that we can save a huge amount of money if we use this pathway. And this is what is going to come up very soon in JPEM as well, the publication that we were discussing about in that regards. And this is the validation of this app, which Riddhi had done, which showed that there was a concordance in over 90% cases in this setting. So this is something which you can use very simply using a growth interpreter. It will tell you the interpretation, and you will get the right diagnosis right away from that perspective. Now, moving on to the next spectrum, which is now becoming more common. Sayan?
Yes, sir. This was a 12-year-old boy who came to us with obesity. He had a height of 160 centimeters and a weight of 70 kg. Now, screening investigations revealed a TSH of 7.91, and the child was advised thyroxine. So, Dr. Rajiv, is the high TSH causing this obesity?
No, this is the other way around. In fact, what happens is in obesity, there is a stimulation of hypothalamic pituitary axis, and the TSH gets raised, but the thyroid gland itself is normal. So there are multiple factors which are responsible, and leptin also one of the factors which is responsible for the TSH rise. So this could be normal, and as the child starts loses some weight, probably the thyroid functions will show as normal. So it will not be prudent to start thyroxine in this particular child.
Very, very important message. It is the effect of obesity and not the cause of obesity, as Sayan put it.
Thank you so much, sir. Coming on to the next case, this was a 12-year-old girl with a height of 130 centimeters. She had a weight of 58 kilograms, normal screening tests, and was reassured. After a while, the child started to have rapid weight gain. So, Dr. Riddhi, what was missed in this case?
So can we have growth chart of this girl?
Yes.
So
yeah.
Yes, so this is the typical growth chart where height age is affected by height age is less than weight age. And so this is typical growth chart of endocrine cause of short stature, needs the endocrine workup and detailed history examination, pubertal assessment for the endocrine cause of short stature. So thyroid function test was normal in this girl, but when we examine this girl, there is typical Cushingoid feature of moon-like face, buffalo hump, hirsutism, and even purplish stria. And overnight dexamethasone suppression test showed the cortisol of 154, which is very high, suggesting endogenous hypercortisolism. So this girl was missed in initial stage because the girl was not plotted on growth chart and she was not examined properly.
So the most important thing to look at in a short child is the weight. The most important thing to look at in a obese child is the height. If you have short and obese, it becomes endocrine, and if you are tall and obese, it becomes constitutional. But what are the exact cutoffs that we should look at? This is our study which Dr. Manoj has been doing in our center. 458 children with obesity. What we found that although this is true, that children who have a pathological cause are short, there is no cutoff. So you can't say, especially for hypothyroidism, you have to do a TSH and FT4 in everybody. That's a message which is coming out of it. So we cannot prove a cutoff which is available in that regards. We have recently also coming up with an obesity interpreter, which Dr. Naveen has been working on. And this obesity interpreter looks at very, very basic things: the current height, the weight, development, facies, as well as puberty. And based upon these 5 things, we give a diagnosis, whether it is pathological, whether it is genetic, vision abnormality, we go for some specific syndromes. So this is going to really help out. On the drop of a button, you will get immediate interpretation from that perspective. So I think that's pretty much the main point, that obesity is usually constitutional. Height is most important. No need to treat mild elevation up to 10, which we'll discuss much more in thyroid section, and short and plump is endocrine. So I think thanks all of you. Thanks Dr. Sayan, thanks Dr. Mahesh, Dr. Rajiv, Dr. Riddhi, and as well as Dr. Anurag Katiyar for this wonderful session. And we'll take a few questions which are there. We'll try to take few of them very quickly and in that regard. So there is a question from Dr. Phoebe. TH is not factoring in 13 centimeter subtraction or addition. So that's a very, very important factor. The novel knowledge, of course, we talk about that when you are looking at child's height, you take mother's and father's height, divide by 2, you add 6.5 centimeters for boy and subtract 6.5 for girls, and then you use a range in that perspective. The studies have shown that the range is actually 1.5 standard deviation score. So when we say that your height is within the target height range, it means that you are within the 1.5 standard deviation in that perspective. The next question is from Dr. Seema Rai. Can IGF-BP3 give us a concrete evidence of GHD and we can skip GH stimulation test? No, both IGF-1 and IGF-BP3 are actually screening tests, and we should not rely on that. We have to do a growth hormone stimulation test. And I would say, given the lack of reliable local reference values available from India and many of the other resource poor countries, it will not a very helpful test from that perspective in that regards. Now, there was a question from Dr. Edele, what is the cost of GH in India? Now, if we talk about GH in India, 1 unit approximately costs around 300 for the international preparation, 300 rupees. And for the Indian preparation, they cost around 150 to 200. So on an average, if you have a 10 kg child who is on 1 unit per day, we're talking about 9,000 rupees a month for the international brands and maybe around 5,000 for an Indian brand. That's what we're talking about. Dr. Naresh is asking about if bone age required to differentiate from SGA and endocrine related cost. So bone age is of course an important part of evaluation. So if you have a SGA child, you will do a bone age because it may be advanced. But if your SGA and not growing, that itself gives you an idea. And bone age is not a discriminatory test. It will tell you whether it is delayed or advanced. It can't differentiate. So the role mainly is height prediction. How much time can you wait? We'll go from that perspective. Dr. Seema is asking if GS resistance is present, so we need higher dose in SGA. Yes, we are not talking about growth hormone therapy. We have got a big module which is available on the web on the IGF deficiency, which talks a lot about growth hormone therapy as well. The key message is that the growth is a bit higher, maybe around 33 microgram per kg in that perspective, which is around 20% more as compared to GHD. Dr. Edele is asking, in case of obesity, what is the cutoff level for hypothyroidism? So if your TSH is more than 10 or between 6 and 10, and if you have goiter or thyromegaly or TPO positivity, you will consider treatment. Otherwise, treatment is not required from that perspective. So again, I'll thank all the panelists for this session, Dr. Mahesh, Dr. Rajiv, Dr. Riddhi, and Dr. Anurag Katiyar, and Dr. Sayan for conducting this session wonderfully. We'll quickly move forward to our second session, which is going to be about a very, very important part of this part, which is about thyroid disorders. And this is, of course, very, very relevant from a clinical perspective, because this is one condition which the pediatricians do see very frequently and often causes confusion. So again, we're going to talk a bit very briefly about the overall assessment of thyroid disorders, and then we will directly move forward with regards to the overall approach and assessment from that perspective. Now, for this session, we have got wonderful panelists which are there with us. We have got Dr. Sonal Shah, who is been associated with us for a long time from the SPMS Medical College, Jamnagar. We've got Dr. Seema Rai from Faridkot, Dr. Manisha from Prayagraj, and Dr. Jyoti from Dharan, Nepal. And Dr. Pratik will be moderating the session. Dr. Sonal Shah, we all know, is a professor of pediatrics in Jamnagar, and she has a keen interest in pediatric endocrinology and in charge of pediatric endocrine clinic. And she has really inculcated the desire of pediatric endocrinology in the postgraduates. We have got 2 of our fellows are actually from her medical college, and a lot of people are actually going through pediatric endocrinology learning. A lot of them participated excellently in the program. So hats off for her for setting and stimulating students in the direction of pediatric endocrinology. Dr. Seema Rai is a very dynamic pediatrician who has been working in Faridkot, and she has done extensive work in terms of pediatric endocrinology as well as medical education, and she's part of a number of IAP bodies which have been working towards education in that regards. Dr. Manisha Maurya is from Prayagraj, and she's been closely associated with MedEClasses for the last 3 years, and she has also been very active in a lot of academic activities. One of our PPECs was done under her leadership in Allahabad, along with Dr. Ritu, who was there. And she has also been very interested as far as medical education in pediatric endocrinology. Dr. Jyoti is, as we've discussed earlier, from Nepal, from Dharan BP Koirala Institute of Medical Sciences, and has done fellowship from Kathmandu, and as well as training from Science School in ISPAD. So we've got a very good faculty. Before we go ahead just with cases, just a few words with regards to the thyroid physiology. Now, we all know that the most important hormone regulating the thyroid axis is actually the TRH, which regulates the secretion of TSH, which then controls the production of T4. Now, T4 is a pro-hormone. It does not cause its own effect. It is either activated via MDI1 to T3 or inactivated to a reverse T3. And this activation, inactivation really decides about how much thyroid is actually there in the body. Very importantly, the T4 and T3 are bound to the thyroxine binding globulin. So the free amount of hormones that we are seeing are actually the ones which are acting, but often we are measuring the total hormone. So there's always a confusion which happens in that regard. So it's always better to measure a free hormone. Now, when we have somebody who develops hypothyroidism, the first thing to happen would be that your thyroid hormones will go down. Your T4 will go down, but immediately TSH will go up. So the body will say, okay, let's get up the level, and T4 will become normal. So the first stage of subclinical hypothyroidism will be high TSH. The second stage will be low T4. The last will be low T3, because T3 levels will fall last, because body will compensate by increasing the MDI expression that will cause more conversion in that perspective. So in Hypothyroidism, T4 and TSH are important. T3 is the most useless investigation. Do not do T3 in that setting. On the other hand, if you have thyrotoxicosis, the first thing to go down will be TSH, if it's basically a primary one, which is the most common form. And the second thing to go up will be T3, because you have got more MDI activity, and therefore you can actually have normal FT4 and high T3. This is what is known as T3 toxicosis. So if you ask me which test to do T3, free T4 and TSH in somebody who has suspicions of thyrotoxicosis, suspicions of hypothyroidism, do a FT4 and TSH. On follow-up for primary hypothyroidism, TSH alone is good enough. On follow-up for central hypothyroidism, do FT4, TSH is useless. For thyrotoxicosis, do T3, FT4 and TSH on follow-up. Now, there's a lot of confusion as to which test to do, and I'll just summarize it very well. TSH has got a 40% diurnal variation, and there is also an interday variation. So when should we do it? Ideally, if you look at, the levels are lowest at the night time. So many people will say night will be a good time to do. But because 40% doesn't make a huge difference, the biological variation is 1,000 times. The range is 0.5 to 5. You can do TSH at any time of the day. Do not wait that, okay, somebody's come from a village 100 kilometers far off, come back tomorrow and we'll do TSH tomorrow. No, you can do the TSH right away. From that perspective, T4 again is important, because if you have taken the drug, the T4 levels will go up. So T4 is not, should ideally be done before the drug has been taken in the morning. So for T4 and FT4, do in the morning. TSH any time of the day can be done. And T3 is a useless test. The only indication of doing T3 is suspected T3 toxicosis. So that's what is to be done. So if you're talking about hypothyroidism, primary TSH should go up, T4 should go down, and T3 will be the last to fall. So do, for that perspective, T4 and TSH, and better would be free T4 and TSH, so that the TBG values are not affected. If you have thyrotoxicosis, TSH will go down, T4 will go up, and T3 will also go up more, as I discussed. So in that setting, you should do all three. And because there are a lot of variations in FT3 is a useless test. So never do FT3, do a total T3. This is how you should do in that perspective. Remember, dynamic changes happen at birth, because as soon as the child comes from a hot environment to a cold environment, there is a TRH surge and there is a huge rise, and therefore different cutoffs have to be used at different age groups. And for that, ideally, you should do a cord blood sample for screening, or better, beyond 72 hours of life. If you are doing in between, you have to do a higher TSH cutoff, which should be used in that perspective. And we have given these cutoffs, so it's very easy to remember: 40, 20, and 10. So first week more than 40, second week more than 20, and then 10 would be a cutoff for treatment. For upper limit for consideration would be 20, 10, and 10. So use these cutoffs very importantly. A lot of people say that it's very difficult to assess, interpret. We can't remember so many values. Sometimes you give nanograms, sometimes you give picomoles. So that causes confusion. So you have to interpret thyroid functions appropriately. And in that regards, remember that always interpret in a fashion in which you have a combined level. So FT4 level and TSH should always be considered together. There is a log linear relationship between FT4 and TSH. If FT4 is low, TSH should be sky high. If FT4 is high, TSH should be 0. That's the basic principle. Now, if your FT4 is low, TSH should be high, above 20, and that's primary hypothyroidism. The biggest message I'm going to give in the slide is that if your FT4 is low and TSH is below 20, do not consider it primary hypothyroidism. 6 to 20, it will still be central hypothyroidism, and clearly you need to be careful, because then you don't want to miss your adrenal and cortisol deficiency. On the other hand, if the FT4 is high, TSH should really be low. That's basically thyrotoxicosis. If you have a detectable TSH adenoma, that's very, very rare in children. Forget about that. The big message is low FT4, TSH below 20. This is central hypothyroidism. Now, how to make sense of it? How to make it very easy? We've actually developed a thyroid interpreter, which is going to come up very soon in our app. All you have to do is to select the age group, put the age, put the value, and you will get the output. So like in this case, it was borderline abnormal, but if the age becomes more from 3 days, you make it 16, automatically the value in output will come. So there are like 80 combination of results which are available, and this will give you a precise interpretation of the group. So if you look at this child who has a picomole value which is on the low for FT4, TSH is more than 20, all you have to do is to just press the button and you will see that this is primary hypothyroidism. But if the TSH was less than 20, let's say it was 15, you will immediately get a clue for central hypothyroidism. So this thyroid interpreter is going to be very, very easy in identifying and making diagnosis in that regard. So we'll start off with the first case. We've got Dr. Prateek, who is working as a consultant at Pediatric Endocrinology at our hospital. And please, Dr. Prateek, start off the case.
Thank you, sir. The first case is a 20-year-old girl. We have been asked for a reference from the NICU, and the doctor says that the TSH has come 28 in the newborn screening. So, Dr. Sonal, how should we proceed from here?
Yeah, good evening. Yeah, as the TSH is, as Dr. Anurag already discussed, whenever because of the child is immediately born, because of the cold stress, the thyroid axis is activated, and there is a surge in TSH value for the first, and it takes at least 48 to 72 hours to get normalized. So TSH, so first of all, TSH should not be done ideally in the first 3 days of life, and if at all, if you want to do the TSH test, you have to interpret it differently. So if the TSH cutoff value is more than 34, then you can think of starting the drug. But in that case also, the test should be repeated after 72 hours. So TSH 28 in first 3 days of life is not the, we should not start the antithyroid, we should not start the thyroxine. So this is the message.
Thank you, Dr. Sonal, for that.
Yeah. So screening should be done after 72 hours, and TSH cutoff value is 34, if between 48 to 72 hours.
Okay. A day 4-old child, on newborn screening, the TSH came 22. So the physician repeated the TSH on day 14 and it came down to 12. And again, on day 21, it came down to 9. The FT4 has been normal throughout. So Dr. Seema, should we wait and watch? Can we keep repeating the TSH and wait for it to come down, or what should we do next?
Good evening and thank you, Dr. Prateek. As we have already discussed by our Dr. Anurag sir and previous speaker, TSH level for first 72 hours, the level at which we should act is more than 40. The etiology has been discussed why this is so. This is as per European Society of Pediatric and Adolescent Endocrinology. As per Indian Society of Pediatric and Adolescent Endocrinology, levels are given 34. And we should keep on repeating if we are not starting the treatment. As in our case, we repeated after 2 weeks and levels are not dropping down. It is not dropping down. And the first week, we should act more than 40. In the second week, after the second week, we should act if the levels is not dropping appropriately. So if after 2 weeks, still the levels are high, more than 20 millinunits, we will treat, we'll start L-troxin, but the situation becomes dicey if the levels is not dropping down. After 3 weeks of life, after 2 weeks of life, level should be below 20. After 3 weeks, the level should be below 10 and the normal value should be reached. So in our case, the level did not drop down to 6 milli units per liter. Hence, we evaluated the patient by doing nuclear scan and which came down to be hemiagenesis. So our patient required treatment in the form of L-toxin. So the key message, if the levels are high and we are repeating, the level should come down and we should always see the age appropriate level of TSH, 40, 20 and 10, first week, second week and third week of life. And if the levels are not dropping down to below 6 after 3 weeks of life, it needs further evaluation in the form of nuclear scan, thyroid ultrasound, and also at the same time, we should look at the normal free T4 level and further treat accordingly. Thank you.
Thank you, Dr. Seema. So another neonate, a 10-day-old child, the TSH was very high at more than 100. FT4 was 11. The thyroid scan showed no thyroid tissue. So, Dr. Manisha, what is the plan here? What do we do next?
Thank you, Dr. Pratik. I think this is obviously a case of hypothyroidism with TSH so high and FT4 low. So we have to start the treatment as early as possible, because there is a window period of 14 days in which we have to start treatment, and treatment started beyond 14 days may have developmental and neurological sequelae. So we don't have to wait and we have to start the treatment immediately. The preparation which is used is levothyroxine, and there is no role of T3. And the brand which is started has to be, we have to stick to that brand, because there are differences between various brands. So we have to use the same brand when throughout the treatment course. And the tablet form is available. The syrup forms are usually not stable. So tablet is given in small babies. Tablet can be crushed and dissolved in the milk and then given to the baby. The dose of thyroxine which is given is 10 microgram per kg per day for dysharmonogenesis and 15 microgram per kg per day for dysgenesis. And the timing of giving thyroxine is 4 hours after feed, or as far as possible, we'll try to have a difference between feed and the thyroxine tablet.
Okay. So this child was started on therapy. Then what happened is the repeat test showed that there was high T4, and actually the dose was progressively reduced, and finally the child was off treatment. So what happened here? How was this progression happening, Dr. Manisha?
So, Dr. Pratik, I think this child could be a case of apparent athyrosis, because when doing a nuclear scan, if we do a nuclear scan, either we can find ectopic thyroid, or there can be no uptake or increased uptake. In case there is no uptake, we have to do ultrasound and in ultrasound, if there is no gland, obviously it is thyroid dysgenesis and it will persist for lifelong. But in this case, the thyroid gland was there. There was a gland obviously found, and it can be eutopic. That is, thyroid gland can be found. The eutopic on ultrasound and no thyroid uptake can be because of either thyroid receptor problem or sodium iodine importer defect, or there can be a antibody, thyroid blocking antibody, which has crossed the placenta and came to the baby, which is now causing hypothyroidism in the baby. So by 3 months of age, this antibodies will gradually disappear and the child may become normal. Yes. So this could be the cause.
So I think very important messages which came from you, Dr. Manisha, in this case was clearly that we need to start high dose. That is the problem, because often we see starting at around 12.5, 6.25, hit early, hit hard. If you're in doubt, start at 50 micrograms. So 3 kilograms, typically 50 would be the dose. Our aim is by the next time you do that, the FT4 should be in the thyrotoxic range. That's what we want to achieve. Now, scan, of course, is very, very important, but if it's not feasible, start treatment, don't wait, as you very nicely said. And again, scan is not a foolproof thing, and you can also have these sort of cases which can be missed. So what are the key messages, Dr. Manisha, from your side?
So all absent uptake are not agenesis. We have to do ultrasound scan to rule out the apparent causes of athyrosis. And the key message is we have to start early, and hit hard.
Thank you, Dr. Manisha. So 4-day-old child, now with TSH more than 100, was labeled as dysharmonogenesis, started on LT4 at 50 microgram. At 4 weeks, it was noted that the TSH came down, but not fully. So TSH was 24, and FT4 has come to the normal level of 21. So Dr. Jyoti, what is happening here? Should we increase the dose of LT4 because TSH has not come down?
Thank you, Dr. Pratik. Here we are seeing in this case, free T4 and TSH is persistingly high, even at 4 weeks of treatment. Still, we shouldn't hurry to increase the dose due to reset hypothalamic pituitary thyroid axis, which will take some time to resolve. And so our target is to keep free T4 on higher side of normal, which may take few months. And free T4 levels are better indicator of adequacy of treatment in this setting. And the levels should be measured after 2 weeks of initiation of treatment and 4 to 6 weeks subsequently. This basically means that we should continue the same dose.
So after 3 years, when the child was reevaluated, it was noted that the child had delayed speech. So what was missed here, Dr. Jyoti?
So this is a case of dysharmonogenesis with delayed speech at 3 years of age. This gives us the clue that every case of hypothyroidism should be evaluated for other assessment, other things as well. We have to do X-ray to look for epiphyseal dysgenesis, and hearing assessment is to be done to see for the hearing abnormalities, as hearing abnormalities and dysharmonogenesis and hypothyroidism is Pendred syndrome. And along with that, we have to even go for developmental assessment as well.
Yes, so the key messages in this case were?
So the key message in this case would be that reset hypothalamic pituitary thyroid axis will take some time to resolve. We have to initially titrate with the free T4 level, and hearing assessment is vital in such cases.
Very important message that do not chase TSH level, because if you chase TSH, you will become thyrotoxic. That's a big message coming from here.
Thank you, Dr. So now we move on to adolescent children. A 12-year-old girl with obesity. She came to the endocrine OPD. The height was 156 centimeters, weight was 56 kgs. There were no clinical features of hypothyroidism. The TSH was done and it came 6.4. And this child was advised treatment. Dr. Sonal, was this a wise thing to do?
As the TSH is 6.4, you obviously think that this might require treatment. But in case, as already we had discussed in the previous module also, because of the obesity, to increase the metabolism, the hypothalamic pituitary axis gets activated. And as a result of this, there is a high TSH, and which gives, so it is because high TSH is not the cause of the obesity in this child, it is the effect of the obesity. So we should not consider the treatment. So whenever you have high TSH, we must do the free T4 level. If the TSH value is more than 10, then you must start the treatment. If it is less than 6, there is no question of the treatment. But if it is between 6 to 10, then we must go for first free T4 level. If the free T4 level is low, then it is required in treatment. But if it is normal, but in this condition, I'm not considering the obese child, but any child who has high TSH with low free T4 and borderline TSH and low T4, we must see for the risk factors in this child. If the child is TPO positive, or some goiter is there, or there is a growth failure is there, in that condition, we must take the treatment. We must consider about the treatment. But if there are no risk factors, we must keep this child under follow-up.
Thank you, Dr. Sonal. So the key messages were?
Key messages is high TSH effect is the high TSH is the effect of the obesity. It is not the cause of the obesity, and you should not start the treatment if the TSH is below 10. And if it is below, if it is between 6 to 10 and the other risk factors are there, then we must consider about the treatment.
Yes, thank you. So the next child is a 10-year-old girl with poor concentration, poor scholastic performance. The height is 136 centimeters. The weight was 34 kgs. Now, when the TFT was done, it was seen that the TSH was 2.4, but the T4 was low, that is 60. Now, Dr. Seema, should we start Thyronon therapy because the T4 is low?
Or should we consider central hypothyroidism in this? Because T4 is low and TSH is less than 20.
Thank you, sir. Thank you, Dr. Pratik. Now we have another case, 10-year-old child presented with poor concentration, and looking at the TFT reports, as there is a log linear relationship between TSH and T4, T4 is low. So TSH has to be raised. So is it really the case? Let us have a look on the normal T4 physiology. T4 circulates in the blood pool along with the transport proteins like albumin, thyroid binding globulin, thyroid binding prealbumin. And total T4 level is grossly dependent upon the level of these factors. In pediatric conditions, there are various conditions like nephrotic, chronic liver disease, in which if these proteins are low, this will be depicted as low total T4. Hence, we should, if the T4 is low, total T4 is low, we should always look at the free T4 level, which we did in our case, and it came out to be pretty normal. to be more sure that we are not missing case of any hypothyroidism, because it is a preventable cause of intellectual disability and causes much more harmful effect at the age of 10, like precocious puberty in girl. So TP also we did, which came out to be negative. Hence, for this patient, we need more evaluation for poor concentration. But for as far as treatment is concerned in the form of L-troxin supplement is not required. So the key message out of this case discussion is, while interpreting report, always look for free T4 rather than even ordering. Don't order total T4, order only free T4 and TSH and plan accordingly. Thank you.
Thank you. So the next case is a 12-year-old girl with lethargy. The height is 140 centimeters, weight is 36 kgs. Here the free T4 is very low at 6. The TSH is 12. And this child was started on LT4 therapy. So Dr. Manisha, was this the wise thing to do because thyroid is low, so we should start, or we should do anything else?
No, I think according as previously discussed by sir also, if FT4 is low, since there is a log linear relationship between TSH and FT4, the TSH should be high. But in this case, TSH is below 20. So it is a case of central hypothyroidism. And the causes of central hypothyroidism, the most common cause is multiple pituitary hormone deficiency. So we have to do a MRI scan and do a anterior pituitary hormone assessment. So if we start thyroxine and there is cortisol deficiency, as in a case of multiple pituitary, it will unmask the cortisol deficiency and child may develop shock. So it is very important to assess all the cases of central hypothyroidism with anterior pituitary functions and MRI scan. So in this child, there was low cortisol level and MRI scan shows empty sela, tersica. So we have to start hydrocortisone and then thyroxine. So the key message is low FT4 with TSH less than 20 is is central, and in those cases imaging has to be done and anterior pituitary hormone assessment. Most importantly, the cortisol levels has to be done. Thank you.
Yes, yes, thank you. So next is a 12-year-old girl with growth failure. TSH is clearly more than 100 and FT4 is low at 6. So Dr. Jyoti, now how do we proceed with this child?
Thank you, Dr. Pratik. So this is a 12-year-old girl with growth failure with TSH of more than 100 milliunits per liter. So we have to start the treatment. Your timely initiation of the treatment is very important with oral levothyroxine. And LT4 is the preferred form of treatment, but there is no role of T3 over, no added advantage of T3 over T4. Dose is 100 microgram per meter square per day, as younger children require higher doses on a weight basis. And for this adolescent girl, so we can also start the dose of 3 microgram per kg per day on the age basis. This would be started on 25% of the day, dose, and then gradual build up of the dose should be done over 4 to 6 weeks period. And the next thing is that the absorption of thyroxine is affected by food. This is very important message. So the drugs should be taken at least 4 hours after or 30 minutes before the meal. And along with that, there should be a gap with calcium, iron, antacid, because it impaired the absorption. So there should be a gap of at least 6 hours between the thyroid medication and these drugs.
So this same child was followed up for a year and TSH was 24, but FT4 is now 26. So now, Dr. Jyoti, do we reduce the dose because this child has high T4 levels?
This is a very confusing picture, Dr. Pratik, as you said that this child's TSH is also high and FT4 is high. Now, what will cause high FT4 and TSH? And this is a dilemma. Now, we have been asked, the fellows are asking whether we increase, other persons in the FT4 is high, decrease. So what should we do, Dr. Jyoti, in this case?
Definitely we have a dilemma in such type of cases, because I even had come across a similar case. So we should ask specifically about the adherence to the treatment, that is levothyroxine is been taken by the child regularly or not. So this seems that the child has started taking levothyroxine just before coming to the pediatric clinic, so we have to ask specifically about the adherence. And dose adjustment is very important. If TSH is high along with free T4, that is also high, then we have to check for the adherence. And if TSH is high with free T4, that is low or normal, we have to increase the dose. And if TSH is low with high or normal free T4, then we have to reduce the dose.
I think this is a lot to do with the half-life of both FT4 and TSH. FT4 is a short half-life, TSH is a long half-life. So by the time a change in dose will have an effect on TSH, it will be 6 to 8 weeks. FT4 will be immediately effective. That's why we say do FT4 before you take the tablet. Now, if somebody has taken tablet for 6 days and he was not taking any medicine, maybe he has taken 2 tablets every day. That's why his FT4 has gone up, but TSH might have been 100. It has become 26, but will take time. So it's again the reset axis. As we talked about in that neonatal case, the same thing is happening again. So understanding physiology really helps a lot in that perspective. The other big message which was there was a gradual replacement. So I think that was a big point which Dr. Jyoti talked about. So maybe a key message is, Dr. Jyoti, from your side.
So gradual build-up of the dose should be done over 4 to 6 weeks time, and timing and adherence to the drug is very important while treating such case of thyroid disorders. Thank you.
Thank you, Dr. Jyoti. So the next case is a 12-day-old child with irritability. We have been called to the NICU, and the NICU in charge says that this child has irritability, has lost weight, 600 grams. On examination, this child has tachycardia, a vacant staring appearance, and the thyroid profile was done, which showed high FT4 and low TSH. Now, an important history the mother gave that mother had Graves' disease and undergone ablation 2 years ago. So, Dr. Sonal, is it possible that the child has thyrotoxicosis despite the mother not even having a thyroid gland?
Yeah, because this obviously shows that child has lost weight also, and child has irritability, and child has tachycardia. So it is definitely, and proptosis is, but there is no proptosis, but this is and high T4 is there. So it is definitely a case of thyrotoxicosis. But now here the question arises that mother is right now not on any drugs. How come the child developed the thyrotoxicosis? So you must remember that that TSH receptor stimulating antibodies, they can cross placenta even if the mother has been fully treated with the disease. So it can cross even after that. So we always must ask the history to the mother whether if the child shows clear-cut signs of thyrotoxicosis. One important history of a mother being treated for Graves' disease, we must ask for it. So we must remember that TSH receptor antibodies, they continue stimulating antibodies, they continue to cross the placenta even after the 2 years of the treatment. So this is definitely a case of thyrotoxicosis.
Key message is here, Dr. Sonal?
Yeah, key messages here is whenever patient has weight loss, tremor, and we must suspect thyrotoxicosis, and eye signs favors Graves' disease. And we hear that drug of choice is methimazole and radioactive iodine, and we must take the history in the mother when the mother has undergone any such treatment for Graves' disease.
Thank you, Dr. Sonal. So now we come to a 12-year-old girl who has history of weight loss and tremors. The TFT done shows a suppressed TSH and high FT4. There is a goiter, but there are no eye signs. What is the plan in this patient, Dr. Sinha?
As the 12-year-old girl child presented with weight loss, tremor, and thyroid swelling, but eye signs still not present. Given that report of FT4 and TSH, this is clear-cut case of thyrotoxicosis. In this slide, showing various commonest clinical picture of hyperthyroidism or thyrotoxicosis. Weight loss is there, hyperdefecation is there. There will be fine tremors. Eye sign, lid lag, chemosis, proptosis is there. Why? When we'll diagnose proptosis, when the upper sclera is present as showing in this picture, there will be periodic paralysis and polyuria. The etiology of these things in the hyperthyroidism is because of the sympathetic surge present in the hyperthyroidism. So how we'll plan? We should go for nuclear scan, but if the eye sign is present, like lid lag and proptosis and thyromegaly is present, we should can avoid the nuclear scan. In our case, the thyroid scan we did showing increased uptake. These are 3 pictures of thyroid scan. First one is showing solitary nodule. Second one is multinodular goiter. In our case, this is diffuse enlargement of thyroid swelling like a butterfly shape. So this gives us a clue of Graves' disease. However, if the nuclear scan is showing decreased uptake, this will go towards thyroiditis. And on examination, if the palpation, if tenderness is there, then it is subacute thyroiditis, and if the no tenderness is there, then chronic lymphocytic thyroiditis. This patient we diagnose is Graves' disease, and we will start antithyroid drug methimazole to control the sympathetic drive like heart rate, tachycardia, CHF. We will start beta blocker, most probably propranolol. But if the patient is having asthma and all, we should start metoprolol and radioactive iodine. So the key message after this patient discussion is, if there is a tremor and weight loss, we should think of thyrotoxicosis. If eye signs are present, then think of Graves' disease, and treatment of choice is methimazole and radioactive iodine depending on the age and various etiological factors. Thank you.
I think that was a very wonderful discussion, Dr. Seema. This key message which comes out is the clinical examination is very important. What is the most common cause of thyrotoxicosis with eye signs? What is the most common cause of thyrotoxicosis without eye signs? So Graves by far is the elephant in the room. If your T4 is very high, above 100, if your eye signs are there, if you have goiter, it is Graves. So 90% it's Graves. In children, thyroiditis is less common. On the other hand, if you have a tenderness, if your FT4 is marginally elevated, you have no eye signs, then do a scan. Don't do a scan in everybody because it's not required. The other big message which came out was a solitary nodule with having thyrotoxicosis. So in that case, you have to really think of it. Do a FNAC if required, unless of course there's a frank thyrotoxicosis, and consider a surgical treatment. That's a big message compared to the adults which comes from there.
So the next case is a 8-year-old boy who is presented to the OPD with the neck swelling. Dr. Manisha, now how do we proceed with this clinical picture?
So a neck swelling near the thyroid region can be 4 types can be there. Either it can be a thyroglossal cyst, or it can be ectopic thyroid adenoma, or it can be malignancy also. So if the benign features of if the swelling is benign, that is, it is not attached to the underlying structure, if it is slowly progressive and is smaller than less than 1 centimeter, is most probably benign. So Dr. Pratik, can you tell me what are the other features like movement with the deglutition and movement with tongue?
Yes. This swelling was a midline swelling. It was cystic in consistency, smooth surface, and it was moving with tongue movement as well as deglutition.
So since the swelling, as told by Dr. Pratik, is movable and is cystic, and it moves with movement with the tongue and with deglutition, is most likely thyroglossal cyst. Thyroglossal cyst is the remnant of thyroglossal tract, which is the tract through which thyroid tissue descends from the pharyngeal floor to the thyroid cartilage. And in most of the cases, it involutes after the thyroid comes to its original place. But in some cases, the thyroglossal tract can remain in the form of thyroglossal cyst, may present later in the form of swelling and pain. Since thyroglossal cysts are more prone to infections, it is better to operate, and a surgical excision is required.
Yes, thank you, Dr. Manisha. So now we have a 10-year-old girl with a thyroid nodule. This child was evaluated by a physician, was initially euthyroid. Even TPO was done, which was negative, and the child and the parents were reassured. But what happened after 1 year, that there was rapid growth. So Dr. Jyoti, what really happened here? What was missed?
Thank you, Dr. Pratik, for sharing such an interesting case. So this is a 10-year girl with thyroid nodule with euthyroidism. So for this type of thyroid nodule, so we should not take it granted that it would be, or it is going to be a benign lesion. So we should have a detailed workup. So we should have we should go for careful assessment of the thyroid nodule is essential. First, we have to focus on the duration, and the course of the swelling is very important in this case. And family history is very vital, as we have to inquire about malignancy in the family, or any history of thyroidectomy in the family is there or not, or history of radiation exposure is also very important. And most importantly, we have to go for the thyroid examination for the size, surface, and if the nodule fixed to the underlying surface and associated lymph nodes are there or not. So hard and so the pointers to the malignancy is the size, which is more than 1 centimeter, which is there in this case, and if it is fixed to the underlying skin, and if there are palpable cervical lymph nodes are there, then that this suggests that there are chances of malignancy is there. And so we should further go for investigation. Ultrasound and FNAC has a crucial role to play. So the key message is thyroid nodule points toward malignancy in 10% of the cases, and ultrasound and FNAC has a crucial role to play.
So Dr. Pratik, I think FNAC is a very, very important message which has come out from this overall presentation. When you do a FNAC, what are the precautions you will take in a child whom you're doing an FNAC?
So we need to see the size before ordering an FNAC, and need to see whether we are taking the proper cell, where we are taking it from. That is also an important point.
So I think that's a very, very important thing to remember, that size is a criteria, but in children, as Dr. Jyoti has very nicely said, it's not just 1 centimeter as a standard criteria. For a younger child, thyroid is smaller. So even at smaller size, you can have a problem which may happen in that perspective. So it's vital that you actually look at other features, especially the ultrasound features, which become very important in that perspective, and that can really cause confusion in certain changes. So the ultrasound features that you should look for include microcalcification, area of solid and cystic area, which may be there, area of necrosis, which may be there. There can be many of those issues which can cause a confusion and problem in that perspective. So that's very, very important. The other big issue is that we, not we in the sense of American Thyroid Association, recommends that it should be a ultrasound guided FNAC in children with nodule. That's a very, very important message, because often you will miss out on that perspective. And very importantly, you need to know that there is a standard criteria, which is the NIH guidelines, which classifies into different aspects on that perspective. So I think what we've done is that we've really gone through the entirety of the thyroid disorders in a lot of detail. And we started right from the dilemmas in terms of congenital hypothyroidism, the importance of doing both FT4 and TSH, importance of looking at thyroid scan, looking at associated abnormalities like hearing abnormalities in that case, crux of primary hypothyroidism in which treatment should be slow and gradual, while congenital the treatment should be very, very rapid and aggressive in that perspective. So I think we'll see if there are any questions, and maybe if there are any discussions with the panelists, because we have really stuck to the time. So very nicely done by Dr. Pratik that we really been on absolute time in that perspective. So we've got some time for discussion as well. There is a question which is there from Dr. Edel, who is asking about, in obesity, what is the cutoff level for hypothyroidism? So I think this point was already discussed by Dr. Sonal. I think I discussed it. Dr. Sonal, what will be your discussion on that?
Yeah, if it is above 10, then definitely you must consider starting the treatment. If it is between 6 to 10, then you may not start the treatment, or you may go for the FT4 level and free T4, FT4 level. And if depending on if there are signs are there, like family history is there, goiter is there, growth failure is there, in that condition you should start the treatment if it is between 6 to 10.
I think that's a very, very important message to consider. And there are a couple of new studies which have come up which are quite relevant in that perspective. There's a recent study which was published in the Journal of Endocrine Society, just this issue of the journal, which looked into the same issue. What happens to children with obesity who come to us with a marginal thyroid? What happens to them? And what they found, that if your levels of TSH are more than 8.7, if you have a goiter, and if you have a strong family history, there is a chance of progression. So this 10 cutoff is very good. So 8.7 is what they found in one study, but 10 is a more generic cutoff. The second study, which actually was done by Riddhi in our setup, was in around 400 children with obesity. we looked into the same issue of subclinical hypothyroidism, whether this subclinical hypothyroidism were doing something or not. Now, the message is very clear that less than 10 don't treat. But what we found that children who had a TSH which was between 6 to 10 had a much higher likelihood of having non-alcoholic steatohepatitis as compared to those whose TSH was less than 4. And when we did a regression analysis, what we found out was that it was the TSH which was a more important determinant of SGPT levels as compared to the BMI or the body fat or other aspects. What we need to understand is that there may be certain situations in which there may be confusion in that regards, and we need to look into that. But for very clear message, do not treat less than 10 in that perspective. The other question which is there from Dr. Sara Mohammed is the cause of elevated TSH in obesity. So again, I think this was discussed by Dr. Sonal, so you can maybe shed more light on that, Dr. Sonal.
Yeah, it is because to increase the metabolism, to compensate for that, there is hypothalamic pituitary axis is activated, and as a result of that is increased TRH, and it which in turn leads to increased TSH. So that is
as discussed very clearly, that body is trying to shed energy, like you want to burn energy. So that's why it says, okay, let's go off and start TRH. The fat becomes more, leptin becomes more, it goes to the brain and says, okay, TRH goes high. But then it realizes that if I burn more thyroid, I will be burning bone, I will be burning muscle. Fat will not come down. So then it stops at that level. So this TSH elevation is related to the fat. It's a sort of a defense mechanism which is stopped because it's going to go do more harm than any good in that perspective. Next one from Dr. Manar Ali is that in patients with high free T4 and high TSH, we might think of thyroid hormone resistance. I think this is an important message. So the thyrotoxicosis part was taken up, I think, by Dr. Jyoti in that regards. Yeah. So how do you interpret somebody who has a high FT4 and a high TSH?
Thank you, sir. If there is high TSH and high free T4, first of all, we have to think of the adherence to the treatment is there or not. First, so if the adherence to the treatment is not there, then we have to think of the other causes.
So Dr. Seema, what do you think if you have a child who is not on treatment and has a high FT4 and a high TSH? First of all, how likely is it? And then what should we do in that regard?
The thyroid receptor hormone resistance is very rarely. So basically, if we will think of the thyroid receptor hormones are not acting properly, there is some genetic mutation or something like that. So we will evaluate accordingly. We will do all nuclear scan, ultrasound.
Yeah. So I think the big message is that if your FT4 is high, TSH should be 0. If you have a detectable TSH with a high FT4, there are only two theoretical possibilities. One is the pituitary resistance or resistance to thyroid hormone, and second is TSH secreting adenoma. Now, TSH secreting adenoma is exceedingly rare in children. It's very rare in adults. It's absolutely not there in children. So I'll say if you have a high FT4 and not even high TSH, a TSH which is detectable repeated, often you will find the level is normal in that perspective. One situation I've seen this sort of a picture is in somebody who is recovering from an illness. We didn't talk about the sickness and the effect of thyroid on sickness. In sickness, what body does is that it tries us to conserve our energy. So it doesn't want to waste your energy. It converts T4 to RT3, which is the inactive form. So the monodiiodinase 2 is active. So you are shunting away your thyroid from acting. But once the recovery happens, there is suddenly an increase which happens in MDI1 activity. And in that situation, your FT4 may go up. So in somebody who is recovering, you may see a bizarre level of levels. You may see a low T4 and a normal TSH, which will go up to high TSH and a high FT4 also. So again, that will be a situation. But I would say in 99% cases, if you have a FT4 with a detectable TSH, it would basically mean that there is an error in the lab. You have to do a repeat testing from that perspective, and that's how it will go on that perspective. But this is very, very important from that regards. There is a question from Dr. Doreen Nichri. How can we access the mobile app such as Bone Assessment app? So these apps are available under the MedEClasses banner. They are available both on Android and iOS stores. You can just go ahead and have download them and you can easily access. There are at least 70 pathways which are there in the endocrinology app. There is a bone age application. There is a growth interpreter. Very soon we are coming up with obesity puberty interpreter. So you can go through the Android or the iOS store and you can get it. Now, Dr. Hamilton is asking, it's important in the case with goiter more than 10 mm that the classification of thyroids be used in the evaluation. So I think that's important from that perspective. Yes. So ultrasound is very important. We always say that in children, the risk of malignancy in a solitary nodule is roughly around 8 to 10%. Earlier, we used to say 15, 20%, but now we say 8, 10%. So 1 in 10 child who has got a level, basically who has got a solitary nodule of thyroid, you're worrying about malignancy. So what do? You look at the size. If the size is more than 2 centimeters, you have to do FNAC in everybody. If it's smaller, go for ultrasound. And then in ultrasound, there are various criteria which are available, which talks about the calcification, the vascularity, and how the size is, how there is internal echoes. We decide whether you need an evaluation. So the thyroid's classification is regarding that. So I think that's a bit beyond the discussion what we are trying to do in that regard. So I think this has been a wonderful session. In the 1 hour, we have tried to cover the entirety of thyroid. It has been really wonderful because of all the participants which were there, because of all the experts, Dr. Sonal Shah from Jamnagar, Dr. Jyoti from Dharan, Dr. Seema Rai from Faridkot, and Dr. Manisha from Prayagraj. Dr. Pradeep did a wonderful job in terms of keeping the time, and we are back. In fact, we were ahead of time and we got time for discussions. So that was really, really wonderful. And I'll thank all of you on that perspective in that regards. So we were supposed to take, thanks all of you. We were supposed to take a bit of a break before puberty, but what we'll do is that, because again, we'll get more time to discuss, so that will be a positive thing. We already have the panelists of puberty session. Dr. Vijay Kumar is already there. Dr. Vishnu is already there. Dr. Manar is also there. Dr. Yotika will be joining. So I think from here, we will move on to puberty quickly. But before we do that, we will have the announcement that everybody is waiting for with regards to the quiz results. So now this was a very interesting experiment even for us. So we always thought that how do we engage people more in terms of pediatric endocrinology? So we tried to do a quiz. Now, since there are a lot of applicants, more than 100 people who registered, we of course can't call everybody on the main platform. So we thought we'll have a prelims round, and that response was very good. And we had over 100 people who participated in the quiz as discussed. And it was a very high quality response, which we found. We deliberately put questions which were very, very difficult. They were quite complicated, and they were all practical questions, no doubt, but they were questions which were a bit difficult in the sense that they had a lot of issues which need to be thought of. Now, we got excellent response. We were expecting people to maybe 50-60% will be the upper limit, but what we found was very good response, which was there. So now the final round of the quiz is going to happen on the Sunday, that's tomorrow, between 5:30 to 6. Before that, we need to announce the winner. So we had 120 participants from 12 countries, very competitive, as I said. In fact, there was a tie at the second and third spot. So we were really happy with the response which were there. So just to announce the winners of the prelims round who have moved to the final rounds, we have got the first or the highest score went to Dr. Devaditya Das, who was from IPGMER Kolkata, and he actually got 20 points. So this was a huge 20 out of 25. We didn't expect that high, but he did really well, and he was the first person to get that point, and he did not share this with him. So this was a very good performance from him. Then we have got Dr. Ramiz Raja, who is a DM resident from Madurai Medical College in Tamil Nadu, and Dr. Ahmad Alam, who is again a DM resident from Banaras Hindu University, Varanasi. Both of them did very well. They got 19 out of 25. So this was just 1 mark separating, but they were tied. Now, all three of them are, of course, DM residents, and that really tells us that endocrinology training also includes a lot of pediatric endocrinology, which is something which we are very happy on that perspective. Just behind them by 1 point was a tie for 3 places. So 3 people tied at 18. And they included Dr. Sawar Agrawal, who is a wonderful academician and who is really, it's really pleasure to interact with him on a lot of practical issues. He scored 18 points. He's from Ekta Hospital, Raipur. We had got Dr. Sanju Joseph, who is again associated with us for some time and has been a wonderful interaction. He also got 18 points and he's from Kerala. And the young person, Dr. Arun George, who is from CMC Vellore, who is currently working as a senior resident there. He also got 18 points. So we now have the 6 finalists which have been chosen. And I will have to say that after that, the crowd was really close. The gap, every point, there were 5-6 people which were there. So it was a wonderful performance. All these people will be fighting with each other to win the first prize, which is a free subscription for the MedEClasses Advanced Pediatric Endocrinology course. And then we have got the other second prize, which is the basic pediatric endocrine subscription. And we've got other prizes as well for all the finalists. All those who participated don't get disheartened because the performance was quite good and we were really happy in that perspective. We will be giving special discounts and options, which are offers which are available for them. We'll send all of you. So all of you done really well. We want you to be more interested in pediatric endocrinology. We'll help you get that. And we hope that next time you will do much better. And maybe we'll have all 25s which will come up for the next quiz. We'll try to share the results also to all the finalists. But this is the team. So all of you don't go anywhere. At 5:30 tomorrow, we will have the quiz session, which will be there. And this is going to be very interesting and exciting from that perspective. So I think we'll wait for you tomorrow at 5:30 to 6 in that regards. So I think we are now going to be close to our puberty session, which is just going to start now. And for the puberty session, we have got a very eminent panel of faculty, which will provide a lot of interaction, a lot of discussion, which will happen in that perspective. We have got Dr. Vishnu Agarwal, who is a professor of pediatrics at J.K. Lone Hospital, Jaipur, which is one of the largest hospitals in terms of pediatric hospitals in India. And we'll just share the screen so that we get the things moving from that perspective. Yeah. And there are 4 panelists. Again, we'll just have a brief introduction and then we'll start right away with regards to cases. So we've got Dr. Vishnu Agarwal from J.K. Lone, Jaipur. We've got Dr. Yuthika from Regency IVF, and she has got a very special interest in pediatric gynecology and pediatric endocrinology. We've got Dr. Manar Ali from Cairo, who has been associated for a long time now with our activities and been active participants in all of those sessions. We have got Dr. Vijay Kumar, who is there from that perspective. So Dr. Manar Ali has been with us for quite some time. She is currently working as a pediatric endocrinologist and has got a special interest. She has done a postgraduate diploma from UK along with MRCPCH, and you will really be impressed by the way she explained things, and it will be very soon you'll identify that. So Dr. Yuthika is currently working as a director of Regency IVF and in charge of the reproductive medicine unit, a keen interest in pediatric and adolescent endocrinology, trained at Royal Women's Hospital and Melbourne IVF, Melbourne. A lot of work with regards to adolescent issues, besides, of course, the IVF and the reproductive medicine part. Dr. Vishnu Agarwal is the associate professor at J.K. Lone Hospital, and we were really lucky to have a PPEC which was done under his leadership in Jaipur, and that was done a few years ago, and that was a wonderful experience which we would like to relive. And Dr. Vijay Kumar, one of my closest friends in pediatric endocrinology field from Calicut Medical College, very simplistic approach, very clear approach, and very down to earth but very knowledgeable factors, and you'll realize that very quickly in that perspective. So I think without wasting much time, we will briefly go through with regards to the overall aspects which are there in terms of evaluation and management, and we'll then move directly on that. So this is a big session, so we'll try to discuss about a number of issues, but we will go one by one in terms of different aspects. We'll talk about precocious puberty in girls, precocious puberty in boys, delayed puberty in girls, delayed puberty in boys, and a few words about hyperandrogenism. So most important part in any clinical assessment is a clinical assessment of pubertal status. And in that regards, often the excuse which is given that we don't have time to do pubertal assessment, it's very difficult. How can we do that? So when we are looking at pubertal development in girls, I will say just focus on two things. Whether the girl has achieved breast stage 2, which is any papilla elevation, and if there is doubt, do a palpation. Now, a lot of us have been trained that it's all inspection, but I would say for breast stage 2, palpation is the key. Now, if you do not palpate, you will miss lipomastia. Now, there will be girls who will present now very commonly with obesity. There is some chest enlargement and they will say, okay, precocious puberty, and the investigations are done, a lot of confusion. So always palpate with your thumb and finger, approximate them and try to feel for an area of resistance which is there. And if there is no resistance, that is lipomastia. Otherwise, it is a normal breast development, which is there. Sorry for that. So from breast stage 2, the growth spurt starts, and you will expect to gain around 20 centimeters from breast stage 2. So what I'm trying to do is to see if you can predict the height based upon the breast development. Now, breast 3 is primary mount. Don't get too bothered about that if you miss it. Do not miss the breast stage 4, which is a secondary mount. This is extremely important because this means that menarche is imminent. From here, the growth is going to be very, very limited. In that regard, you will gain around 10 centimeters. The typical time from breast stage 2 to 4 is around 2 years. That's when the growth spurt is happening. And once the girl starts having vaginal discharge, it means that you have got impending menarche and the growth is limited. And after menarche, the growth is only 5 to 8 centimeters. So 3 key messages here. 1, if you have a girl with 130 centimeters at B2, you expect her to go to 150. If she is at B4, it will be 140. And if it is menarche, only 135 to 138. So just always correlate yourself with regards to breast development and with regards to your height, you will get the final height. The second big message is lipomastia. Don't miss that. The third is that the normal gap between breast 2 to breast 4 is around 2.5 years. If you have a short gap, it means that you had something which is producing huge amount of estrogen. There is some breast development, but you have vaginal bleeding which is happening immediately. And that would basically mean that there is a peripheral form of precocious puberty. If you have a vaginal bleeding at breast stage 1, it is not endocrine. It is a local cause. It may be trauma, tumor, abuse, infection. It is not a case of precocious puberty, and this is what we'll discuss subsequently from there. Pubic hair development is relevant, but you have to be careful. Pubic hair 2 is reasonably common, and often we get referrals of pubic hair 2, which may not be significant. These are just slightly more than the abdominal hair, slightly blackish hair, but they are not curly. They are not pigmented. They are not dark. This is stage 2. Yes, worry, but not too much. And often in infancy, you may see 1 or 2 pubic hairs, which are in the labial regions. Again, this is not a cause of concern. But the moment you have a stage 3 pubic hair, which is a dark, pigmented, curly pubic hair, it is a cause of worry. So stage 3, again, is a cause of concern in pubarche. Others, of course, you can easily correlate. And we will show how combining breast and pubic hair, you can make a diagnosis for both precocious puberty as well as delayed puberty. So pubic hair is, in our algorithm, very, very important part to evaluate and assess. In boys, of course, is the testicular volume, which is most important. So all of us should have an orchidometer, which is very important. As soon as the testicular volume goes beyond 4 ml, it means that the child has entered puberty, and beyond 10 ml is the pubertal spurt. If you have a voice change, that is equivalent to menarche. So if you had 4 ml and child is short, wait. 10 ml, less likely, don't wait too much. But short at voice change, gone. You're not going to have much growth happening in that regard. So as in girl, B2, B4 and menarche, here you can say TV4, TV15, 10 to 15, and then voice change. That's the equivalent as far as boys are concerned. And this is what you need to understand. So now, if you go to our application, all you have to do is just to compare visually, and we'll show that how you can easily identify the pubertal assessment from that regards. Now coming on to precocious puberty, which is by far the commonest presentation for girls in the endocrine clinic. It is common in girls, 2.5% of all, but 90% and above are physiological. Most girls with precocious puberty have a central precocious puberty, and between 6 to 8 years of age, this is basically in the setting of it being a physiological variant. While physiological causes are more likely in girls, pathological causes are more common in boys. So precocious puberty in girls is defined as onset of pubarchy and thylarchy before 8 years of age and vaginal bleeding before 9.5 years of age. So if you have any of this, you need to evaluate an approach, which is very, very important. So when you are identifying in terms of precocious puberty in girls, look at the extent of puberty. That's fine. So the most important thing is that look at pubarchy. If there is just pubarchy, look at DHEAS level. If DHEAS level is the most important part in anybody who has got pubarchy, if the DHEAS level is less, then it is a simple case, don't worry too much. If it is 40 to 135, this is adenarchy. But if it is more than 135, it is significant. So DHEAS is very important. If DHEAS is very high, think of a pathological cause, rule out CAH and do imaging. If your serotonin OHP is low, adrenal imaging becomes important. If it's high, it becomes CAH. If you have isolated vaginal bleeding, breast development is not there, only vaginal bleeding, look at local cause. And if there is a complete development of thylarchy, look at bone age. If the bone age is retarded, this becomes hypothyroidism. If the bone age is normal, it is slowly progressive. And if it is advanced, look at LH to differentiate whether it is peripheral or central precocious puberty. So the most important thing to look at, how much is the involvement? Just pubic hair, look for DHEAS. And if the DHEAS is high, rule out imaging and CAH in that perspective. If you have vaginal bleeding, local cause, and if it is a complete development of thylarchy, look at bone age, delayed bone age. In that perspective, think of hypothyroidism, normal, slowly progressive, and advanced, look at LH level to classify. So this is the way it should progress from that perspective. We'll start now with the first case. Dr. Naveen will come up and go from there.
We have this 7-year-old girl who was actually referred from outside church with concern for breast development. And on
I think AC on.
Which was actually mentioned in the description was that she had breast infection with no menarche and
AC
she
तो गर्मी लग रही थी
was going at a height of 180 centimeters, which is normal for age. And the bone age was also normal for chronological age, which was 6.5 years. And she had a pre-pubertal hormonal level, LH of 0.1, LH of 2.2, and estrogen was contributing. And do you think this is the case of precocious puberty, and what could be the cause of isolated thylarchy and the bone age is normal and also the heart rate is normal?
This girl of 7 years presented with isolated thylarchy. Her bone age and height age is not advanced. Her LH and FSH are in the pre-pubertal range, and estradiol level is also not elevated. Whenever we come across a case of precocious puberty in girl, first we have to confirm the presence of precocious puberty. In case of isolated thylarchy, we have to differentiate it from lipomestia, which is a very common presenting complaint in case of obese girl and boys. Lipomestia can be differentiated from true breast development by palpation of areola with the help of thumb and index finger. In case of lipomestia, when we approximate thumb and index finger, no resistance will be felt, whereas in case of true breast development, breast nodule will be felt. Since in this case, no breast nodule is felt, her bone age and height age is not advanced, and estradiol level is also not elevated, which can be confirmed by examination of vaginal mucosa. All these findings are suggestive of lipomestia. After confirming presence of precocious puberty, we have to define its extent into isolated thylarchy, isolated vaginal bleeding, or isolated thylarchy or complete precocious puberty, and we have to evaluate accordingly. Since this is a case of lipomestia, we have to reassure the patient. Important message coming out from this case is that we have to confirm the presence of precocious puberty before doing any detailed investigation, and lipomacia is a very common presenting complaint among the obese girl and boys.
Thank you for the lovely detailed explanation. And moving on to the next case, we had a 2-year-old girl with concern for breast development. And according to the mother, the onset was around 6 months ago, and it was slowly progressive. And on examination, we found that she had a breast staging of 3 with a pubic staging of 1 and no menarche. So is this a case of precocious puberty, and do we need to start treatment here, Dr. Manna?
Yes, regarding this case, she presented with a 6-month history of thyroid, which is breast enlargement. Her parents were really worried about this patient. However, assessing her height attainment in terms of growth velocity, she was slowly progressing in terms of her height attainment. Besides, there was no hair development in the pubic area, and there was no menstrual bleeding. Also, there were no any skin pigmentations that such as pigmentations which doesn't cross the midline, ruling out McCune-Albright syndrome. Having this thyroid doesn't go with the pathological highly progressing to full pubertal attainment. Going through her basal FSH and LH values, the LH didn't approach the 0.3 number. Besides, her estradiol levels were less than 10 picomole per liter. Confirming her internal organ growth, her ultrasound showed the microcystic variant. It's physiologic. We call it the small cysts. So putting all together, the basal gonadotropins were in the normal prepubertal range. Her estradiol level was less than 10 picomole per liter. The ultrasound reassured us that she didn't cross the pubertal measurements and age. So we reassured the parents that this is an isolated thyroid, and all the history goes with this. Of course, doing the bone age also could confirm, if we did the bone age, would confirm that her bone age didn't exceed the limits of the 2-year. So to go through the conclusion, isolated thyroid is a common entity. However, careful breast examination can afford us reassuring measurements in the clinic by doing the approximation of the thumb and the index finger to the breast tissue, which we usually find resistant or not, so that we can say this is lipomastia. However, this child has this thickening in the breast tissue, but her condition was not progressive, so she only needs reassurance and follow-up.
Thank you so much for the.
I think that's a very important message. And I think one thing which is important to understand, that often when we talk about pubertal assessment and hormonal assessment, there is a phase called mini puberty. Now, in mini puberty, as Naveen, you will see that levels really go up and the LH levels may remain high for some time. So when we talk about the LH discriminatory levels of around 0.2 for central versus 0.1 for peripheral, this is not really true when we're talking about these infants. Now, if you see in that these cases, we should use a higher LH cutoff of around 0.6 rather than using the lower cutoff. And sometimes, if the clinical picture is non-progressive, wait, watch, don't worry about that. So isolated thyroid is by far the elephant in the house. A girl who is presenting to you with just breast development, which is not progressive, 99% is isolated thyroid. Only 1% may be McCune-Albright. You will have cafe au lait spots, you will have vaginal bleeding. Or very rarely, you can have a hypothalamic hematoma. There the LH will be 3-4. So don't get confused. We get a lot of confusions because the LH was 0.6. Now what will you do? Will you do MRI? Will you start treatment? Treat for how long? So in these cases, borderline LH elevation, don't worry, it may be settling of mini puberty which may be happening in that perspective.
Thank you so much, sir. And moving on to the next case, we had a 6-year-old girl who came with a concern for breast development. And according to the parents, it was around 1 month ago, and she was growing really tall for her age. And she had also pubic hair development of P2 staging and a breast development of B3 staging, and her vaginal mucosa was pivotal, which was pink. And when we plotted her anthropometry on a CDC chart, we found that she was growing tall for the age, and she also had an advanced bone age of around 11 years. So what do you think, Dr. Mana? Is this a case of precocious puberty, and does she require treatment here? Dr. Vijay?
Okay. Can you go to the previous slide?
Yes.
I think you can just, in contrast with the previous case, you can see that this 6-year-old girl, her height is more than expected. Her height is above 97 centile. That is the most important thing, and that the essence is you have to plot the growth chart very carefully to see whether the child is having precocious puberty or a simple premature thyroid. You can see that her height is in the 97, above 97 centile, and you can see the bone age. Bone age is advanced. These are the very simple investigation that will tell you that you are not dealing with a simple case of thyroid. This is a case of precocious puberty. And you can go down. You can see that her pubic hair and breast development is advanced, and they see the vaginal mucosa. The vaginal mucosa is pink and pale. That indicates that the effect of estrogen is already there. So you are not dealing with a simple case. You are dealing with a case of precocious puberty. Next slide. So whenever you have plotted and you have seen that she is tall and advanced bone age, so you can see that the child is having thyroid and the bone age is advanced, and she is do an LH. The bone age is 11 years and do an LH. Her LH is advanced. If the LH is above 0.3 units in or between 0.1 and 0.2, you can do a GnRH stimulation test. Then if the LH is advanced, if it has after stimulation, if it is above 5, then you can think that you are dealing with a central precocious puberty. And in girl, if the age is between 6 and 6, above 6, you may be dealing with a physiological, that clock is shifted little bit advanced, and the chance of finding any abnormal thing in the imaging is less. But if it is less than 6 years, you have to do an MRI, because that may be pathological. Unlike in boys, most of the cases are pathological. So she is having a definite case of precocious puberty, and she will improve with GnRH analog.
I think one very, very important message which Dr. Vijay has given here is the clinical examination, especially in terms of the assessment of the vaginal mucosa. Now, we know that estrogen levels are not very reliable in terms of assessment, and this we'll discuss in another case, where the low levels may not be reliable. So if you look at vaginal mucosa, and vaginal mucosa in a girl with precocious puberty should always be pale. If it is red, it is not estrogenized, and this is something else. So this is very important clue you have given. So Dr. Vijay, your messages from this case?
So here, any case of precocious, any case of breast development and precocious puberty, the height and a carefully plotted growth chart is the very essential thing. And next is the bone age. With these two things, we can differentiate whether you are dealing with a physiological cause or pathological precocious puberty. And as Dr. Anurag is discussing, the careful examination of the vaginal mucosa is very important. Pale and pink mucosa is an estrogenized mucosa. Red and glistening mucosa is a non-estrogenized mucosa. And if the bone age is advanced, you are dealing with a central precocious puberty, and you can go ahead with GnRH analog after doing the tests.
Thank you, Vijay Kumar sir, for throwing us light on the evaluation and assessment of precocious puberty. And next, we want an interesting case where there's a bridge and we need the help of our colleagues. And we had the 7-year-old girl who came with the complaint of vaginal bleeding, and it was just a single episode. And on other examination, there was no breast development or pubic hair development, and the vaginal mucosa was red. So what do you think is the cause of vaginal bleeding, Dr. Yutika?
So I think this again is a very, very interesting situation that we're dealing with, of a case in which we have got somebody who has got.
Can you hear me?
Yes, yes.
Yeah. So now this is basically a case of what we say is that a girl is non-estrogenized and yet bleeding. So her she is no breast development, no pubic hair, and the vaginal mucosa is red, meaning there is no estrogen in the body, and yet she is bleeding. So this is not a case of precocious puberty or isolated vaginal bleeding. It is something, a local cause, or more what we call as the vaginal cause, gynecological cause of vaginal bleeding. Such a case should be definitely referred to a gynecologist for looking, ruling out any local causes like infection, foreign body, trauma, and even rarely you can have vaginal rhabdomyosarcomas or the vaginal tumors that can present like that. Clinically, if I say that, how to differentiate between gynecological cause of vaginal bleeding from the endocrine cause would be to look at pubic hairs or look at the breasts. So if there is no pubic hair and no breast development, you're most likely dealing with a non-endocrine cause of vaginal bleeding, which is mostly local. So if there is only breast development and no pubic hair, it is something related to hypothyroidism, and presence of pubic hair, it might be adrenarche, and presence of both pubic hair and the breast stage development, that only would be central precocious puberty.
So I think this really highlights the importance of looking at just two things. Forget about everything. Look at breast and look at pubic hair. If you do that much in a girl with pubertal disorder, be it early or late, 90% your diagnosis is right. And this is very, very important point, which will show how it can really give you a precise diagnosis without much testing at all. So this case, nothing there. Local cause, of course, becomes important.
And we got the hormonal testing done, and it was as expected to be in the pre-pubertal age with LH of 0.1, less than 0.1, and FS of 2.2, and estradiol was in the normal range. And vaginoscopy was done, which showed foreign body. So what are the take-home messages from this case, ma'am?
So the take-home message is, if there is no evidence of any, breast development, you should always think of local cause as a cause of vaginal bleeding, and gynecological workup should be done to rule out any infection, trauma, tumor, or any basically even sexual abuse could be one of the reasons. So gynecological referral is a must in this case.
I think just associated with that, there is a very common finding, Dr. Yutika, which children come to us as complaints of vaginal discharge. Now, in the setting of somebody who has got no breast development and somebody who's got some breast development, how do you correlate both of them? And which children should be immediately referred to a pediatric or a gynecologist in that perspective?
If there is no breast development and somebody is having vaginal bleeding and vaginal discharge, it could be related to what is known as vulvovaginitis. And usually this is a very itchy condition where, children scratch and they have the bleeding due to that, or because the vagina is inflamed, it might have a breakthrough bleeding from the vagina. So if there is no breast development and vaginal discharge, that is when you should look at, and if the vaginal discharge is profuse, that could be, or foul smelling, those are the key pointers where it might be a cause of concern, a gynecological cause. But if there is breast development, sometimes estrogenization also leads to vaginal discharge, and that has to be differentiated by history and workup.
Thank you. And thank you for beautifully explaining the difference on where the gynecological intervention is required and where the endocrinology intervention is required. So next we move on to another interesting case. We had a 7-year-old girl with concern for breast development, and she had a onset of breast development which was 3 months ago, and she was extremely short for age. And on examination of the ultrasound, we found that she was having multiple cysts on her ovaries. And on plotting the anthropometry in the growth chart, we found that the height was actually extremely short for the age, and she was found to be growing extremely short. And on examination, she was having a pubic staging of 1 and breast staging of 3, and vaginal mucosa was pink and it was easternized. So what could be the cause of a short girl with puberty? Dr. Vishnu.
This girl of 7 years presented with thyroid of 3 months duration. What is important in this case that her present height of 100 centimeter is significantly retarded for her chronological age. This is in contradiction to the growth advancement, which is usually seen in cases of precocious puberty. Also, what is important that a big size ovarian cyst is visible on ultrasonography of abdomen. This large ovarian cyst is because of high TSH in case of hypothyroidism acting on the FSH level. So delayed bone age, delayed growth in case of puberty is suggestive of hypothyroidism, which can be corroborated by high TSH level in this case.
What will you do, Dr. Vishnu, in this case for the cyst? Will you do for surgery? This is a very large cyst.
No. There is no requirement of surgery. We have to treat hypothyroidism as per standard protocol, and it will gradually regress. There is no need of surgery in this case.
This is a very, very important message. And another message which Naveen has given is that if you have any girl with precocious puberty, she should be tall. Any girl with precocious puberty who is short, who has a delayed bone age, think thyroid. That is a very, very important thing. Other rare things, the brain tumor, which is causing concomitant DHD. But as our application is showing, if you have a delayed bone age, always think of hypothyroidism, check TSH in that situation.
So what are the take-home messages?
Growth failure because of hypothyroidism is a only cause of delayed bone age in case of precocious puberty, and ovarian cyst in case of long untreated hypothyroidism is because of very high or extremely elevated TSH level acting on the FSH, leading to the formation of ovarian cyst. And these ovarian cysts in case of hypothyroidism does not need surgical intervention. They can be simply regressed by treatment of hypothyroidism as per standard protocol.
Thank you, sir. Moving on to the next case, we had an 8-year-old girl with concern for breast development. On examination, she had a breast staging of 3 with pubic hair staging of 2, and she was growing tall for her age with a height of 147 centimeters. And the bone age was actually very much advanced with a bone age of 11.5 years. And
so if you look at this girl, this is very different from the previous case. You are seeing that there is a significant breast development, there is pubic hair development, and there is also a bone age which is advanced. So this is opposite. Now, why did you not get a pubic hair enlargement in that case?
So pubic hair enlargement, that could be because of the hypothyroidism. So hypothyroidism, what basically happens is that there will be increase in the level of FSH and not the LH
prolactin
level
will go up. Because of the hypothyroidism, the prolactin will go up, and that prolactin will suppress LH. So you did not have pubic hair there. So again, as Dr. Yutika showed, large breast, no pubic hair, think thyroid, because hyperprolactinemia will cause suppression of pubic hair. This is a classical. So central precocious puberty, as discussed, is more of a progressive thing. So you have stage 3 with pubic hair too.
And as expected, the hormonal levels are in the pubertal range with LH of 3.1, FS of 2.2, and surprisingly, the estradiol levels were very low. And when we look at the examination of the vaginal mucosa, it was also in the pubertal range, where it was estradiol, it was pink and pale. And this is a definite case of precocious puberty, but the estradiol levels are very much concerning. So what do you think for the low levels of estradiol in this case, Dr. Mana?
Yes, of course, this patient is coming with the full clinical pictures of puberty. Looking for her age, this is precocious, especially when you find that the height is on the plus 4.2 standard deviation score, which means that there is a progressive growth. The bone age confirmed that the difference between the chronological age and the bone age is more than 2 years, 3.5 years. The basal LH and FSH are really going with central precocious puberty. This is gonadotropin dependent. However, the estradiol is less than 10. We should think of what's called SA essay references. I mean, going for some essay in the labs can make this estradiol falsely low. What I mean that when you look to the vagina, it is already pale. This means that there is an affection of the estrogen on the local organs of the child in terms of the external genitalia. So this is, as mentioned, it is a falsely low level of estrogen due to assay references.
Very, very important message. And what we need to understand that most labs, when they do estrogen, they do via the chemiluminescence assay. And these chemiluminescence assays are built to assess estrogen at levels of 100, 200 for adult women. If you're looking at 10, 20, 30, often they will do error. So if you really want to do a proper assessment of a girl who has early puberty, you should go for assays which are based on structure and not based upon immunity. You should go for a GCMS based assay. Or I would say your stage 3 development, your bone age is advanced, your LH is high, your vaginal mucosa is pale. Forget about estrogen. This is precocious puberty. So estrogen is not reliable marker in this setting.
And what are the take-home messages in this case?
So the take-home message that we should look to the patient globally in terms of the clinical assessment, the history, along with the physical examination we saw that the child, and we should not rely basically on the estrogen as the solo factor for deciding the condition of the patient. We should take all the parameters altogether. Besides, assessing the local vagina in terms of the mucosa is helpful. Actually.
Thank you so much. And we move on to the next case.
I think the other big message which was there was the LH level being most important. So when you're looking at a girl with precocious puberty, LH, as Dr. Manar has said, is the most important. In this case, was very high. So I think more go clinical. If you want to look at one parameter, look at LH. One imaging, go for bone age. That is the message Dr. Manar just complimenting on that part.
Yes.
Moving on to the next case, which was similar to the second case which we saw. We had a 1-year-old girl with concern for breast development. And in this case, according to the mother, it was within 3 months of duration. And she was growing actually tall for the age at the height of 88 centimeter and the weight of 12 kgs. On examination, there was no pubic hair development and she had a breast staging of 3 and vaginal mucosa was not easternized. It was red and glistening. And when we got the hormonal levels done, we had a LH of less than 0.1 and FSH of 0.1, and estradiol was slightly the higher range for the age group. So what could be the cause of this isolated breast development in this case? Could this be a isolated thyroid or infancy, or it could be something else?
Definitely in this case, yeah, she does have a significant breast development. The duration of breast development is short duration. And her pubic hair, it's not present. The estrogenization probably was transient because the mucosa is red. And the hormonal workup is showing that LH is and FSH is low. So any cause of peripheral puberty or a transient cyst or an exogenous addition of estrogen could be, if somebody is giving. So of course, this patient has labial adhesions. So very commonly for labial adhesions, many doctors use estrogen creams, local estrogen creams, which they apply in the vulval region for absorption of the adhesions, and they get absorbed and can produce a picture like this. So I think she should be inquired about the topical estrogen, and that should be stopped with the reversal of the symptoms will happen. Here I would like to mention that labial adhesions are a very benign condition, and they happen due to physiological hypoestrogenism that occurs usually in this age group when the child is weaning away. So all the intrauterine exposure to estrogen that the child had in her mother's womb goes away, and the vulval epithelium becomes really thin and soft, and many times it basically fuses. Usually, it's a benign condition, and usually it becomes better on its own, and it does not require treatment, especially in an asymptomatic girl. And whenever you are starting treatment, basically it has to be told to the patient that it can lead to precocious puberty, because local topical absorption of estrogen can have a picture like this. Yes.
Thank you. So what are the key home messages from this case?
So whenever you have a low LH, it's a sign of a peripheral precocious puberty, which could be due to a transient ovarian cyst that came and it went away, and or it could be, an exogenous application of estrogen. The key message here would be to, especially for pediatricians, because parents become really, really worried when they see a label adhesion, and label adhesion in a large majority of patients who are asymptomatic do not need any treatment. It gets better on its own, and definitely topical estrogen treatment can have its own side effects. Thank you.
Thank you. Thank you so much for the lovely explanation on the importance of history taking, and also explaining details regarding the cause and treatment of label adhesion. Next, we'll have the...
So we have now discussed about the girls. What about the boys? I think the boys' evaluation is more important, because while precocious puberty is less common in boys, there is more likelihood of having a pathological cause. So we all know that it's the GnRH which controls the secretion of LH-FSH, which secrete the estrogen, out of which LH is the most important factor, because it regulates the Leydig cell to produce testosterone. Now, there's another organ which produces androgens, which is basically the adrenals. And if you have precocious puberty in boys, the problem can actually come either from the hypothalamus, which is the central precocious puberty, in which you will have large testes. And I'll say the most important thing to look at in a boy with precocious puberty is the testes. The most important thing to look at in a girl with precocious puberty is pubic hair. The most important thing to look at in a boy with precocious puberty is the testicular volume. So if you have a central precocious puberty, your testes will be big, because they are producing the hormones. While if you have, and of course the LH level will be high, and we use 0.2 as a cutoff in that regards with pubertal testes, which is more than 4 ml. While if you have a problem in the testes or in the adrenals, typically because of a congenital adrenal hyperplasia or rarely a adrenal carcinoma, your testes would actually be small. So small testes, precocious puberty, peripheral, large testes, central, intermediate testes, it can really be something which is acting on the LHCG receptor, that is the HCG producing tumor in that regards. We also need to remember that if we have untreated peripheral precocious puberty, with time, there will be a secondary trigger and the testes can become a bit more. So these factors have to be considered in that perspective and understand. The pubertal progression in boys, we already discussed that we have to look at testicular volume of 4 ml, which means that you have entered puberty. More than 10 ml means you are going to have a growth spurt, and a voice change means that there is subsequently very limited time available. Do a proper evaluation. So precocious puberty in boys is defined as onset of pubarchy and testicular volume more than 4 ml before 9 years of age, and then you have to consider. So we'll start off again with a case of Dr. Naveen.
Thank you. Moving on to the next chapter of dealing with precocious puberty in boys. We have an interesting case of a 4-year-old boy with concerns of pubic hair development and change in voice. And on examination, he had a testicular volume which was almost equivalent to that of the adult size at the age of 4 years. So what could be the cause, and what would be the next line of management in this case, Dr. Manna?
So this is a case in which we have got a large testis and who is having precocious puberty at a very, very young age. So Dr. Manar, are you there? So this is an important situation to discuss about. And what do you think, Naveen, from your perspective? If you, let's say this testicular volume is around 10 ml, what do you think of this? This could be?
Sir, as you already mentioned, the most important aspect in evaluating a patient with precocious puberty in boys is to looking at the testicular size. It is very much increased for the age, and it is definitely suggestive of central cause. So this is more likely to be central in origin. So we need to get the hormonal profile done in this case.
Now, if you are thinking in that perspective that this is central precocious puberty, what is the likelihood of it being a pathological cause according to you? Is it low or high?
In case of girls, in this age, it is also high. So in almost all cases of precocious puberty in boys needs a definite evaluation. So finding a pathology is very extremely high. So we need to get a MRI done to rule out any sinister pathology.
So this is what we were talking about. If you have got large testes bilaterally, this is central precocious puberty, just like this case. If you've got small testes, that is more like a peripheral precocious puberty. But be wary if you have an intermediate size testis. Now, what do you mean by intermediate size testis? What I'm trying to say is that if you have a penile development, which is very significant, but testicular volume is not going above 8 or 10 ml. Now, we use cutoff of 10 ml because if it goes beyond 10, it has to be central. Because if you have a HCG producing tumor, or if you have that situation, your testicular volume may go up to 8. Now, why is there a difference? When you have a central precocious puberty, testis becomes big. When you have a HCG producing tumor, you only have a slight enlargement, be it HCG tumor or testotoxicosis.
It is basically because of the fact that when it is central, it LH and FSH both acts on the Sertolic and Leydig cell, and the measure of the testicular volume, which is about 60%, is determined by the Sertoli cell size. So what basically happens in this case, it is basically the LH or the SCG, which is almost similar chemically, and it acts on the LH receptor and cause an increase in testosterone level, and this does not act on the Sertoli cells. So that is that is responsible for not increasing in size in such cases.
So very important message, because only the Leydig cell is rising, you would basically get a slight increase in testicular volume, but testosterone will go haywire. So that is important. So TV more than 10 ml, definitely central, less than 4 ml, definitely peripheral, 4 to 10 ml, think of a HCG dependent cause, testotoxicosis, be it a possibility of a HCG tumor. Now, Dr. Manar, are you there? I think there's some connectivity issue there. So as discussed in this case, we will look at gonadotropin levels, which were high. So LH is 2.2. For me, 2.2 is huge. You're talking about 0.2 in that perspective. Let's put it this way. If you have a thyrotoxicosis, your FT4 is high, TSH should be 0. If you have a peripheral precocious puberty, your testosterone is high, your LH should be 0. So any detectable LH is suggestive of a central precocious puberty, but we use a cutoff of 0.2. Earlier, the assays were not very good. People were using radioimmunoassay, that's why the cutoff was 0.6. Now we talk about 0.2 as a cutoff. This is 2.2. This is a clear-cut sign of very high levels. Something needs to be done, and we need to do an imaging. And what do we find here, Dr. Naveen?
So we find a hematoma in this.
So what is really a hematoma? Hematoma is a normal tissue in an abnormal tissue. This is not a pathology, it's not a tumor, it's just that you have a normal hypothalamus which has gone beyond outside its control, and therefore it goes haywire. It says, I don't believe in GABA, I don't get suppressed by glutamate, I don't get stimulated, no effect of kisspeptin, I'll work independently. So it's like you've got some rebel who has started his own government somewhere else and creating chaos. So hypothalamic hematoma is causing such early development, causing so much chaos, and this requires treatment. Now, would you send for neurosurgery?
So in this case, we just need to start
Never even think about sending them to neurosurgery, because the next moment you will hear that they would have their hairs shaved and they would have had the surgery done. So very important message is that there is no role of surgical intervention here unless you have a large hematoma, which is more than 8 centimeters inside, giant hematomas, or if you have uncontrollable seizures. Now, what type of seizures do you see in this setting?
So we see gelastic epilepsy, commonly with
So such early onset, this is hypothalamic hematoma. Keep it to yourself. Don't send to your neurosurgery colleague, because we have seen cases who are taken up for surgery and become very, very difficult to manage from that perspective. And again, very, very clear that this case is a case of central precocious puberty because of increased testicular volume. MRI should be done in every boy, whatever age. In girls, less than 6 years, MRI is essential, 6 to 8 years if there are neurological features in that perspective. Next case, please. Dr. Manar is back, I think.
Yes, yes. Unfortunately, I missed I have a problem in the connection, but I fixed it already.
No worries. So I think just the key message you can again give in this case with large testis, I think the key messages were these two. Any points you want to add?
Yes, I believe you mentioned every point that unilaterality and the bilaterality of the testicular volume is a significant marker to just delineate the background of the illness, whether it is central, peripheral.
Yeah, so I think that's very, very important message.
Yes.
So we'll carry on to the next case. Navi?
Yes, we have a 7-year-old boy who also had similar issues similar to that of the previous patient. But in this case, we found that the testicular volume was actually corresponding to the age. So what could be the cause in this case, and what would be the approach in this case, Dr. Vijay Kumar Shah?
Okay, as we have discussed in the previous case, in a male with precocious puberty, so the most important important clinical examination is estimating the testicular volume by a Prader's orchidometer. So in this child, compared to the earlier child, the testicular volume is remaining prepubertal. In the first case, the testicular volume was enlarged, and this is prepubertal. So we are dealing with some problem in the peripheral. So that is peripheral precocious puberty, not a central cause. So you have to search for adrenals. That is the most important thing, and testis. So the one thing is gonadotropins. Usually in a peripheral precocious puberty, you will get low levels of gonadotropins, LH, if it will be less than 0.2. And the next important thing is look for adrenals. It can be the most common things. So here the LH is 0.1, FSH is 1.2, and testosterone level is high. So that is a peripheral precocious puberty. First suspicion should be adrenal. And the commonest thing and the most commonly missed thing is congenital adrenal hyperplasia. So the next important thing should be an estimation of 17-hydroxyprogesterone, and if the child is having hypertension, look for 11-deoxycorticosterone also. So it may be 21-hydroxylase deficiency. If the child is having hypertension, that can be 11-hydroxylase deficiency also. And see, they do an abdominal ultrasound, look for the adrenal gland hyperplasia. And the next important thing will be adrenal tumor. So that also you have to keep in mind. And if the testis is irregular, so one testis is large and other testis is normal, you have to look for the cause in the testis itself. It can be a testicular tumor producing precocious puberty. Here you can see that the adrenal imaging, adrenal gland is enlarged, and 17-hydroxyprogesterone is sky high. It is 120 nanogram per ml, and this is a case of 21-hydroxylase deficiency. So this is a very common case of peripheral precocious puberty. So the key message is, in a child, in a boy with precocious puberty, you have to look for testicular volume. And if the testicular volume is prepubertal, you are dealing with a case of peripheral precocious puberty. And the next important thing will be to rule out congenital adrenal hyperplasia. And estimation of 17-hydroxyprogesterone is most vital thing.
Thank you so much. And next, we move on to the discussion with delayed puberty.
So delayed puberty again is an important factor to consider, and it is a common presentation in boys. Girls, it is common, but often the girls don't present with those complaints. They come more with precocious puberty. But in girls, you have a much higher likelihood of a pathological cause. This is important to remember. But remember, 1/3 still will be physiological. Often we have been told that CDGP does not happen in girls. That is not true. 1/3 of them actually will have a CDGP. But boys, 2/3 will have a constitutional delay and 1/3 will have a disorder. So if you have a girl presenting to you with delayed puberty and a boy presenting to you with precocious puberty, think this could be something wrong. If you have a girl 6 to 8 years of age with precocious puberty, boy 14-15 years of age, some delayed puberty, wait and watch. Don't get too aggressive in that regards, and that understanding becomes very, very important. Delayed puberty in girls is defined as no thelarchy by 13 years, or if there is a discordance between thelarchy and menarche. I said 2 to 2.5 years, but if you have a gap more than 5 years, you will consider it to be significant. The main approach here is to distinguish between what is known as hypergonadotropic hypogonadism, in which the FSH is high, from hypogonadotropic hypogonadism, in which the FSH and LH are low. But most importantly, every girl, before you start treatment, look at growth. Look at other parameters. Look at pubic hair. Look at pallor. Look at clubbing. All these things are very, very important. Look at blood pressure. And I will show how it is important. Very importantly, before doing any workup, do the screening investigation. So as in short stature, we talk about CBC, liver function, renal function, celiac, and thyroid. Every girl, before you do any investigation, do that. Prolactin, in my experience, never very helpful, but you should not miss hyperprolactinemia. That's important. Once you have done all that, look at FSH. I would say FSH alone is good enough. If the FSH is high, now what is high? In our experience in girls with Turners, it will be very high. It will be like 30, 40, but sometimes there may be a confusion. If it's high, do a karyotype. If it is a low, this is central. Think about from that perspective. Let's start off with this case of delayed puberty.
Moving on to the next aspect of our discussion with regards to cases of delayed puberty. We had a 13-year-old girl with concern for delayed puberty, and on examination, she did not have any form of breast development or pubic hair development, and she was growing normal for her age with a height of 145 centimeter and a weight of 40 kilos. And she had a hormonal profile in the pre-pubertal range of LH of 0.1 and FS of 0.1. And to everyone's shock, she ultrasound showed absent uterus. So the parents are very much concerned, and they were really shocked on seeing this report. And what do you think, Dr. Yutika? Do you think there is any gynecological intervention required in this case, or do you need to work up in aspects of androgen insufficiency syndrome? Could you please throw light on this aspect?
This is not an uncommon case that I see in my practice, because as Dr. Anurag also said, that delayed puberty is, although in a large number of girls an abnormality, it's a very big concern also for parents, and they turn to come quite early. So if you look at the definition of delayed puberty, if there is no the age cutoff is borderline for this girl. So if you just look at the clinical picture of the girl, am I audible? Yeah.
Yes, sir. Yes, ma'am, you're audible.
So she is clinically prepubertal, and she has no breasts, no pubic hair. She's growing well. She's just right at the cusp of 13 years of age, where we would expect her to enter into puberty, because it's the upper limit where girls do enter there. Her hormonal work is prepubertal, and she's probably just a prepubertal normal girl. And very commonly, if the ultrasound, a trans-abdominal ultrasound is not properly done, and if the person is not trained well enough, or the machine is not up to the mark, it's very common to miss a prepubertal uterus. So very commonly, they will report as a rudimentary uterus, or a small or absent uterus, because a prepubertal uterus is like, just like a fold of, it looks like just a fold. It's very, the anteroposterior diameter is very thin, and it requires a trained hand to pick it up. So generally, if there is no breast, I would suggest that you should not go in for an ultrasound for uterus. If you cannot see the breast, it means that the girl does not have estrogen in her body, and the estrogenization of uterus in the stage 1 of breast is quite low, and the uterus is small and very easily missed. In this case, I would have not even done the hormonal workup, reassured, and kept her in follow-up. But now, because the ultrasound has been done, it's a devastating diagnosis. Usually, Mullerian agenesis is a hormonally completely normal girl. They have complete full secondary sexual characteristics, and they have an absent uterus. So in this girl, we need reassurance, waiting. But we want to give a take-home message. Please have the next slide. That you should not get an ultrasound for uterus done if clinically, the girl does not have breast development, because many times it will be missed, it will be a miss, and then you'll have to get an ultrasound done from a better center to reassure the parents. It's going to be really difficult. In this case, I think we just need follow-up, and she probably will enter puberty in the next 6 months.
Thank you, ma'am. And we move on to the next case. We had a 16-year-old girl with complaints of delayed puberty, and she had no breast development and pubic hair development on examination. And she was extremely short for her age, with a height of 135 centimeters, and she was also not gaining weight properly, with a weight of 28 kilos. And she had a hormonal profile done, which was in the prepubertal range of LH of 0.2 and FS of 1.1. And she was started estradiol by the treating physician. And was it right to start estradiol in this case, Dr. Vishnu?
This girl of 16 years presented with the complaint of delayed puberty with breast and pubic hair stage 1. What is important in this case is that her present height of 135 centimeter and weight of 28 kg are less than third centile, and they are significantly retarded. In case of delayed puberty, significantly retarded height and weight age suggest underlying systemic disorder as a cause of delayed puberty. Low LH and FSH, prepubertal LH and FSH in this case also corroborate with this dictum. Since weight is also retarded in this case, I am more in favor of underlying systemic disorder as a cause of delayed puberty rather than CDGP. In case of delayed puberty, a simple examination of breast and pubic hair, we can have a fairly good idea about the underlying etiology of delayed puberty. In case of girls, absent breast development with normal pubic hair development suggests GnRH deficiency, whereas absent breast and pubic hair development suggests CDGP or underlying systemic disorder as a cause of delayed puberty, as in our case. Normal breast development with absent pubic hair development suggests androgen insensitivity syndrome, whereas normal breast and pubic hair development in case of delayed puberty suggests some underlying congenital malformation as a cause of delayed puberty.
Yes, sir.
In our case, significant anemia was also present, and TTG was elevated. This is suggestive of celiac disease. Whenever we come across a case of delayed puberty, first we have to do certain screening investigation to rule out underlying cause. And always consider systemic cause with low LH. And anemia in case of systemic disorder such as celiac disease.
Thank you so much, sir, for the wonderful explanation and approach to a girl with delayed puberty. We move on to a next interesting case of a 12-year-old girl who actually presented with a growth failure, and she was extremely short for age, with a height of 122 centimeters and a weight of 27 kilos. And on examination, she had no breast development and pubic hair development, and she had the features of Turner's syndrome in the form of brachymetacarpia and webbing of neck. And as expected, when we got a hormonal profile done, our FSH was sky level high, which was 88. But the treating physician directly started on growth hormone therapy. So was it right to start on growth hormone therapy in this case?
Actually, when we are talking about delayed puberty, we should not miss such a case, because Turner syndrome is a multi-system disease with special consideration regarding the karyotype of the child, because even though the child doesn't have a distinctive features of Turner syndrome, microdeletions of the X chromosome cannot give these features. So in a child with a short stature, the possibility of Turner syndrome should be ruled out. The second point, when we start with the growth hormone, actually it is one of the requirements of giving growth hormone is Turner syndrome. But should we give it immediately, or we should do the karyotyping first? So when we see the next slide, please. After the her growth hormone treatment by her physician, A few months after that, she presented with increase in her abdominal girth, and on examination, she showed an abdominal mass. And when we did an ultrasound, we will astonished by finding that she has what's called gonadoblastoma. Digging further in her karyotyping, she was mosaic for the bi cell lines. I mean 46XY and 45XO, and meaning that she had the Y chromosome in her DNA methylation assay. So one of the devastating effects of the giving growth hormone without fully investigating children with Turner syndrome is not doing the probe for the Y chromosome or demethylation, so that we can give the growth hormone without causing any malignancy in the hidden ovaries. Also, the children with Turner syndrome, we should go do a battery of investigations, and we should give the parents the chance and the option to choose to do what's called the cryopreservation of the ovarian tissue, should she think of getting pregnancy in her adult life. So the take-home message for this case is that we should investigate any child, any girl child with short stature by excluding Turner syndrome. And if this should there be any possibility of giving her growth hormone, the Y chromosome should be ruled out, so that she should not have the devastating effect of inducing malignancy. Gradual induction also for children with Turner syndrome in terms of giving starting low and going slow for the estrogen, the estradiol, by giving her 0.2 microgram.
Yeah, so I think that's an important thing, that we should always do a karyotype, even if we have, but as I said, even if from the space you can see that this girl looks like Turner syndrome, do a karyotype. That's important. Carry forward.
Thank you so much for explaining the importance of karyotyping in a patient with Turner syndrome.
Okay. Okay. Okay.
Moving on to the next case, we have a 16-year-old girl with a complaint of primary ammonia. On examination, she had a breast staging of 4 with no pubic hair development, and she was actually normal for her age, with a height of 160 centimeters and weight of 52 kilos. And when we got the hormonal profile done, we found that the FSH was very high of 88, and LH was also very high of 45, and we found that the estrogens were negligible, and there was no features of hirsutism. So what do you think is the cause in this case, Dr. Vijaya?
So this is an interesting case. Always, whenever you are dealing with a girl with delayed puberty, you have to think of this case. So here the main problem is child is having good breast development, but you can see that there is no pubic hair. That is one important point. And she is not short. She is having an average height 163 centimeter, and you can see that FSH level is very high. And you can again see that estradiol level, she is not producing much estrogen, and so there is no hair distribution at all. So in such case, as if you just remember that algorithm in the previous case, if the child is having, if the girl is having good breast development and no pubic hair development, you have to think of androgen insensitivity syndrome. So
I think that was a very, very important message. Yeah, please carry on.
Okay. So here you have to suspect that this child is having an androgen insensitivity syndrome. The key message is that whenever, so here the pubarchy is a vital clue. Whenever the child is having delayed puberty, she is tall and good breast development and no pubic hair development, you have to think of a complete androgen insensitivity syndrome. A partial androgen sensitivity syndrome may come with ambiguous genitalia. Okay.
Thank you so much.
I think that's a very, very important thing. If you have a primary amenorrhea patient, all you have to look at is breast development and pubic hair development. If you have no breast development, this is delayed puberty. Work up accordingly. If you have got no breast development is there, but pubic hair development is not there, it is androgen insensitivity. If you have got both, breast is also developed, pubic hair is also developed, look at hirsutism. If hirsutism is there, you are dealing most likely with hyperandrogenism. If it's absent, you're looking at a local cause. So again, just look at breast and pubic hair, you will get your diagnosis both for precocious puberty, delayed puberty, and primary amenorrhea. And that's what really was very nicely pointed out by Dr. Vijay in this case.
So moving on to the next case, we had a 14-year girl with complaints of hirsutism, and she had her menarche, which was 1 year ago, and she used to have her periods every 2 months, and on examination, her Ferryman Galway scoring was 6, and USG was suggestive of PCO appearance. So this was the USG which she had, and this is really a case of PCOD, Dr.
Again, this is a very common presentation in a gynecological clinic where, you have this ultrasound picture of polycystic ovaries in a young girl who has mild hirsutism, has a bit of irregular period, and had a recent menarche. Now, in my opinion, this should not be labeled as polycystic ovarian syndrome because her hirsutism is so, it's just a mild hirsutism. It's sort of hyperandrogenism of puberty. Her menarche is just a year back. So her hypothalamic pituitary axis is not mature enough to have an adult kind of periods. So this is just a physiological state that the girl is in. So it's, we should not be labeling her as PCOS, although we should keep her in follow-up to see how her periods mature and she, develops into a completely normal person. So coming on to PCOS in adolescent girls, I think it's very important to say that PCO appearance, so the ultrasound picture of polycystic ovarian morphology is not a criteria for diagnosis of PCO in adolescent girls, because here the ovarian size is, as it is, much higher than adult women. They do have the multicystic appearance that happens in the peripubertal and the perimenarchal age group. So PCO is not basically what we need is irregular period, and documented clinical or biochemical hyperandrogenism. Basically, if you can, just put in the slides. So the testosterone needs to be high, or if there is hyperandrogenism clinical, you should look at moderate to severe hirsutism, a Ferryman Galloway score of more than 8, I would say, and severe refractory acne would be a clinical hyperandrogenism, or a documented high testosterone level of a cutoff of 60 that we have now, 55 to 60 that we have now started, regarding as higher level of testosterone. And now the diagnosis should be at least, if this has persisted for more than 2 years after menarche, then only we should be, looking at, and even then in adolescent age group, we say it is at risk of PCOS because 50% of these girls with good lifestyle management would grow out of this condition and will not develop the adult type polycystic ovarian syndrome that we are seeing nowadays. And other causes of hyperandrogenism also need to be ruled out. So that is also very important, because any cause of hyperandrogenism will lead to a polycystic ovarian appearance or in irregular periods. So it's very important to rule that out.
I think that's a very, very important message. PCOS is actually an unexplained ovarian hyperandrogenism which is persistent. So you have to have ovarian etiology persisting more than 2 years and being unexplained. That's very important. Just a PCO morphology, useless in adolescent age group. I think that's what is very, very important from that regards. In last 2 cases in puberty, and we'll push forward towards our next session then.
We move on to the next case, where a 16-year-old boy who came with concern for puberty, and he had an onset actually which happened 3 years before, and it actually stopped after 2 years. After for the last 1 year, he is not having any form of pubertal development, and on examination, the testicular volume was found to be 3 ml, which was soft and a pubic hair staging of 3, and he was actually tall for the age with a height of 170 centimeter. And the treating physician diagnosed this case as a CDGP. Do you agree with the diagnosis, doctor?
Okay. So here, this is a 13-year-old boy, and he has a very peculiar problem. He is having arrested puberty or stalled puberty. So he noted that around 13 years, this child started having his testicular development or features of puberty, but it is not progressing. That is the problem here. You can see that testicular volume is just prepubertal 3 ml, soft, and pubic hair is there. That is, you can see the discordance. Pubic hair is stage 3, and he is tall. His height is good, 170 centimeter. So the diagnosis of constitutional delay in growth and puberty is not correct, because constitutional delay and growth and puberty, he will be having short stature, and the puberty will be delayed, and the pubic hair development also will be delayed. Here they have started his puberty but stopped or arrested or stalled in between. So the point is against CDGP is the presence of pubarchy. So pubarchy will be delayed in CDGP, and normal growth. Usually constitutional delay and growth and puberty will be having the short stature, but it will be going in a lowest centile. So the child will be having neurological features. The classical example of this arrested or stalled puberty with a tall stature is a Klinefelter syndrome. So the things like that we have to look for, and don't reassure the parents that this is a CDGP and will improve.
I think the big message is that while 80% of them will be CDGP, if you have somebody who is not short, who is having pubarchy, his bone age is not delayed, think of a pathological cause.
So we move on to the last case of our discussion. We had a 17-year-old boy who had a similar complaint of pubertal concern, which he had onset around 5 years ago, and it was almost stopped 3 years before. And on examination, he had a testicular volume of 2 ml, which was firm, and have also had features of gynecomastia. So what do you think would be the diagnosis in this case?
This boy of 17 years presented with concern for delayed puberty. Initially, he had normal pubertal onset at the age of 12 years, and now from last 3 years, there is no pubertal progression. This clinical presentation indicates stalled puberty and suggests acquired cause rather than congenital cause. On examination, his testis is significantly smaller in size with firm consistency, and significant gynecomastia is also present there. Significantly small testicular size with firm consistency with gynecomastia suggests underlying testicular cause of delayed puberty in this case. In cases of delayed puberty due to presumed testicular failure, we would like to do FSH level and testosterone level in this case. In this case, FSH level is significantly elevated and testosterone level is low. We did karyotype examination in this case, and which was suggestive of Klinefelter syndrome.
So I think this is a very, very interesting case that we saw, and you had small testes with gynecomastia in a tall child. That is Klinefelter written all over that. Key message, Dr. Vishnu?
In case of delayed puberty in boy, we have to do FSH level, and FSH level is suggestive of underlying testicular cause of delayed puberty, and we have to follow it up with karyotype examination. And stalled puberty is suggestive of acquired cause rather than congenital cause.
Very, very important. Thanks a lot. I think, and just to summarize, that we have actually developed a puberty interpreter which really helps out in terms of making diagnosis. All you have to do, so in females, you don't even have to enter basically in terms of their breast or pubic hair stages, just you have to collect which stage the patient is. Once you do that, you will get a particular diagnosis based upon height, bone age, breast, and pubic hair, just 4 parameters, and you will get a likely diagnosis from that. Similarly, in boys, our pubertal interpreter based upon the testicular volume and the pubarchy status, just 2 parameters and the age, will give you a clear-cut diagnosis which will be there in that perspective. So what we're trying to do is that with the use of very basic parameters, we are able to achieve a good outcome in that regard. And this study, which we have recently sent for an abstract, shows that with this sort of an interpreter, we are able to have a very high concordance in terms of diagnosis. So puberty interpreter is something which will make life very easy. This whole 1.5-hour lecture will go just on your button, and you press it and you will get the diagnosis from there. I think that has been a wonderful session. Of course, this was one of the most challenging sessions, a long sessions. I'd like to thank all the panelists who were there, Dr. Manar Ali, Dr. Yuthika, Dr. Vijay Kumar, Dr. Vishnu, and Naveen for handling it so nicely. and this was really interesting. I'll just say if there are a few questions quickly. There is a question regarding microsurgical resection of hypothalamic hematoma, again not required for precocious puberty, only if there is concern for seizures which are refractory, you would do in that perspective. Now there is another question which has come from Dr. Rashmi, a 11.5-year-old girl with B3P3 vaginal discharge since last 4 months, but no growth spur. What may be the cause? Is she going to attain menarche soon? Vaginal discharge is the time of peak growth velocity. And from there, 6 months, you expect menarche to happen. So there may be some other cause which is affecting her growth. Think of a possibility that there could be actually hypothyroidism or some other acquired cause which is there. Dr. Ashubu is asking about a girl with age of 6 with bilateral breast enlargement, ultrasound prepubertal, no breast tissue, axillary hair and pubic hair prepubertal, bone age is 7. It regressed but returned this year with 5-month history of progressive breast enlargement. What should I do now? And this is an important situation because often we do see a stuttering pubertal growth. Some of them may have puberty for some time, it goes off, goes on again. So we are actually working out, and Science is trying to do a study about predictors which will suggest the possibility of the parameters which can predict the progressive puberty. So now in this perspective, if you have a child who has got a breast stage going beyond stage 3, if you're having a uterine endometrial thickness beyond 3 mm, bone age more than 2 years advanced, think of progression, and this becomes important in that regards. So I think there's last question again from Dr. Ashubu. At what age should we advise for dry preservation of the eggs in a girl with Turner syndrome? I would say these are all experimental therapies. Not a single pregnancy till date has been reported in that regards. And there is a whole algorithm that we have in our application, which we'll discuss. But I will say that this is more of experimental. You need to send to a reproductive medicine specialist. Dr. Yutika, maybe you can have the last word on that before we close this session.
Yes, definitely. Fertility preservation in a girl with Turner syndrome is still experimental. And what they recommend for a girl is a total, rather than an oocyte cryopreservation, an ovarian cryopreservation, wherein they do a laparoscopic oophorectomy and do ovarian cryopreservation. So even in those cases, not even a single case report. And for oocyte cryopreservation, doing an AMH level and consequently also repeating it, if it is falling, then the chance that you will get an egg is also low. But a laparoscopic procedure, and it's something which is very tedious. So offering them oocyte cryopreservation as a form of fertility preservation can only be done for girls who entered puberty on their own and had a good AMH value.
And very importantly, it's not just about having eggs, it's about complications which pregnancy can cause. You have to look at coarctation, blood pressure, there's huge issues. So pregnancy in Turner's is not just about fertility. There are many more issues, and this could be a life-threatening situation as well. So I think it's been a wonderful session. I have to thank Naveen, Dr. Yutika, Dr. Manad, Dr. Vishnu, and Dr. Vijay for this wonderful session. And we'll move forward to the last session on this day 1 on office pediatrics, which is on a very, very complicated topic. That is the topic of DSD. And this is something which everybody is scared of. This is something everybody thinks that they should not get a case of, but everybody needs to be ready for that. And for this, we have got a wonderful panel, which is going to take us through this discussion. The panelists for this session are Dr. Purnima, Dr. Varuna, Dr. Neha, and Dr. Sajili, and Dr. Manoj will join me with regards to specific questions and how we'll have case scenarios which will be discussed. Dr. Purnima is a senior faculty at St. John's Medical College, and she's done fellowship under Dr. Raghupati. Dr. Raghupati, in fact, has trained a huge number of, he's really made a sea change in terms of pediatric endocrinology scenario across the country. She is currently working in St. John's and has done a wonderful work in terms of type 1 diabetes in that regards. Dr. Varuna is currently working as Associate Professor in Department of Pediatrics at AIIMS Jodhpur. She did her training at LHMC and MAMC, and she has also been actively involved and has done training under Dr. Ram Menon, Professor Ram Menon at Michigan, and has been involved in pediatric endocrinology care. Dr. Neha is our protege. She was one of our first fellows with Dr. Chetan, and she did a wonderful tenure in pediatric endocrinology at CDER Kanpur, and now currently working as assistant professor at HIMSS Himalayan Institute at Dehradun. She has also undergone fellowship in Liverpool under Dr. Senthil. And Dr. Sajali, our next protege, she worked here for pediatric endocrinology, also trained at Wadia Children's, currently working at Jupiter Hospital and Mymar Hospital as well. And she's also involved in terms of a lot of pediatric endocrine activities. So this is going to be a power-packed session with complicated things. Before we go into the intricacies, just a brief introduction. So when we say DSD or disorder of sexual differentiation, we are talking about a discordance between the genetic, gonadal, and phenotypic expression of that particular individual. So there can be various variations which may happen. From a clinical perspective, we can divide DSD into XX DSD, which essentially means that this is an act of commission. Every individual who doesn't have any hormones, who doesn't have any estrogen, doesn't have any estrogen receptor, no testosterone receptor, will have a default development towards the female as perspective. So for an XX individual to develop DSD, you need to have something active which is there, and that could be in the form of either you've got androgen excess, which is coming mostly from the adrenals, or from the ovaries because of the aromatase problems. 95% of cases would, I will say, 21-hydroxylase deficiency. So if you have a XX DSD, it is a life-threatening condition. Exclude 21-hydroxylase deficiency immediately. How would you know that? Just look at, you will have no gonads and you will have a Mullerian structure. When we'll talk about DSD, as we talked about puberty, you said you look at breast and pubic hair. Here you're looking at gonad and Mullerian structure. So no gonad, Mullerian structure present, it is XX DSD even before your karyotype comes in. In this situation, think of CAH. Others are very rare, gonadogenesis and aromatase deficiency. And aromatase deficiency should be considered if you have maternal virilization. The mother gives a history that there was acne, there was hair growth, and maybe clitoromegaly during pregnancy, which went off. So this is for XX DSD. The most complicated ones are XY DSD. And as I said, XY DSD is an act of omission. Something has went wrong. Your gonads did not develop, testis does not develop, testosterone was not formed, dihydrotestosterone was not formed, or there was no action. This is a more complicated picture, a much wider presentation. The classical clinical picture which we'll see in XY DSD will be gonads are present, but you don't have any Mullerian structure. So again, 2x2 table, look at gonad, Mullerian structure, you will get the diagnosis. XY DSD can be because of problems in gonadal development, in which you have to look for kidneys, adrenals, and other factors as well, or impaired production of hormones, which may be associated with an adrenal problem as well. So you may have salt wasting in proximal defects, you may have hypertension in specifically 17-hydroxylase situation, or you can have isolated testosterone deficiency. Then you have complicated picture in which you've got both Mullerian structure and gonad, and this is something tricky. So what we'll do over the next half an hour or so is to go through a lot of cases which will really good in that perspective. Before that, we need to know what really is DSD. So anybody with atypical genitalia is DSD, but if you have bilateral cryptorchidism, that's a dangerous sign. That could be a sign of salt wasting 21-hydroxylase deficiency in an XX individual, and the child will die if you don't treat. Penoscrotal hypospadias, yes. Any phenotypic male with bilateral cryptorchidism and severe hypospadia requires evaluation. Any phenotypic female who has got inguinal gonads, be it in the newborn period or be it later on, also requires evaluation in that perspective, and that becomes absolutely important from that regards and understanding in that situation. Now, again, just a 2x2 table. If you have got just the Mullerian structure, no gonad, this is XX DSD. If you have got just gonad, no Mullerian structure, this is XY DSD. If you've got both, you're talking about a AMH problem or a ovotesticular DSD. And if you've got none, it means that gonad was there. Maybe now it is abdominal, or it is gone. It may be anorchia. So this, I think, is the fundamental aspect, which is very, very important from that perspective. And this is how you can proceed from there in that perspective. So we'll start off now with the first case. Dr. Manoj, please come up and start the part.
We have 40-year-old Peter come by concern with atypical genitalia. On examination, picture showing like this. So, Dr. Voluna, what will you advise for this patient?
So this child has presented with complaint of clitoromegaly, but she does not appear to have any labial fusion. And does she have any palpable gonads?
No.
No palpable.
So there are no palpable gonads. There is no labial fusion. What is the size of the clitoromegaly?
It is less than 0.9.
So anything that is less than 1 centimeter does not really need workup. It is just a physiological variant. We can just reassure the parents and leave it there. So prominent clitoris is not something very significant, does not need workup.
We have second case, a 3-month-old girl having no vaginal opening, no clitoromegaly, no palpable gonads. Parents came with that concern of this kind of genitalia. What do you will advise, Dr. Purnima?
So this looks like a phenotypic female, and with a, can I get the picture, please?
No. Just relax.
So phenotypic female with a clitoris which appears normal, and there's a single opening. So what I could notice is there's a structural abnormality. So and no evidence of palpable gonad as per the picture.
No palpable gonads.
Yeah. So the structural abnormality, probably it could be a labial adhesion, and vaginal opening is probably obscured because of the structural abnormality. So
what will be the take-home message for this patient?
Yeah. So most important point is clitoromegaly is very important to proceed for the DST evaluation. And labial adhesion per se doesn't require any workup to be done, and no intervention, as Dr. Yutika had mentioned earlier in her earlier talk, like it appears around 12 to 24 months of age due to low estrogen deficiency. Unless there are symptoms of UTI or recurrent UTI, then requires an intervention for the labial adhesion.
I think the big message very clearly which Dr. Purnima has given is that if you're thinking of a labioscrotal fusion, clitoromegaly is essential. You can have clitoromegaly without labioscrotal fusion. You cannot have labioscrotal fusion without clitoromegaly. That is a big message which is there. So this is labial adhesion and not really a DST.
We have another patient, a patient referred from pediatrician, a 2-month-old boy having this kind of genitalia. Parents concerned about the DSD and patient having penile hypospadiasis. We did stretch penile length that was 2.8 centimeter. Patient having palpable gonad will well from scrotum, and there is gonad is present. So Dr. Neha, what you will advise for this patient?
Thank you, Dr. Manoj, for the inputs, and you have already examined the case well. So as we have seen in the previous 2 cases, like isolated clitoromegaly and labial adhesion, this case is also not a case of DSD. So a careful evaluation of the stretch phallic length and the gonads help us rule out the cases of DSD and prevent the child and the family for unrequired stress and investigations. So this child does not need any workup. And coincidentally, I encountered a similar case in OPD today, which was referred from the surgery department. So these are one of the most common cases which are referred to us. So child visited the surgery department for this hypospadias, and from there, child was labeled as DSD and was referred to our OPD today. So one needs to be aware of the normal variants as well.
Okay.
Thank you.
We have another case, a 8-year-old boy referred for the small phallic size. Examination showing boy is obese, height is 130 centimeter, and weight is 44 kg. So boy having obesity with testicular volume is 2 ml. Dr. Sajili, what you will advise for this patient? Either it is DSD or not.
So thank you, Manoj, for the update. So this case, he is an obese child, but before labeling the phallus as small, we need to measure it. Okay, so what was the stretched penile length in this child? Can you elaborate on that?
SPL was done, that was 6 centimeter, and patient having no any polydactyly or no any syndromic features.
Yes. So one important thing is in patients with obesity, most of the time the penis is buried because of the peripubic fat. So one needs to measure the SPL, and only after seeing that how much is the stretched penile length, we can label it as small phallus. Sometimes obesity can be associated with small phallus in some syndromic conditions like Bardet-Biedl or Prader-Willi syndrome. But before labeling it as small phallus, one should always measure the stretched penile length. And I would say that is the most important message from this patient case, that we don't need to work up any child before measuring the stretched penile length.
So what will be your key message for the patient?
So in this patient, any patient who presents with obesity and a small looking phallus or a small looking penis, one should first measure the stretched penile length, because buried penis is the most common presentation in obesity.
I think that's very, very important. In the first 4 cases were very essential to understand that we should not evaluate everybody. If you just have a prominent clitoris, if you have got labial addition, if you've got penile hypospadia, if you've got micropenis, it is not DSD. Do not waste your workup, because when you say DSD, your workup becomes too much. You think of karyotype, you think of testosterone, DHT, 17-OHP. So you don't need workup in these cases. Let's go to the real cases who need workup.
We have 3-day-old child. Parents came with concern for the DSD, examination showing this, and patient having no palpable gonads and Prader stage 4. So what do you think, Dr. Varuna, for this patient?
So this child is a 3-day-old child and Prader stage 4 with no gonads, and the Mullerian structures are present. So this is definitely a case of XX DSD. So I would be very concerned with this 3-day-old child, because this child is at very high risk of being a case of 21-hydroxylase deficiency. So I would like to see what is the status of the 17-hydroxyprogesterone levels in this child. And also, if 17-hydroxyprogesterone, apart from that, what is the status of DHES and deoxycorticosterone levels? That is available.
Okay. So in this child, there is no palpable gonads, Prader stage 4 with no gonads, and uterus is present. So it is 46XX. Sodium is low, 120. Potassium is higher side, 6.1 centimeter, and 17-OHP is pretty higher side, 120 nanogram per ml. So
what do you think, Dr. Varuna? Now this case seems to be what you were thinking right from the beginning. Hyponatremia, hyperkalemia, 17-OHP. What do you? How do you proceed from here?
So this is an absolute medical emergency, because if not picked up in the time, these children can come in shock and sometimes even die undiagnosed. So this child has got definitely, because 17-hydroxyprogesterone levels are also raised, and child has got salt wasting. So this is a case of 21-hydroxylase deficiency, and this child needs to be immediately started on stress dose of hydrocortisone. And once the child has been stabilized, we can gradually shift to lower doses of hydrocortisone at around 10 to 15 mg per meter square per day, along with mineralocorticoids, fludrocortisone, 100 to 200 micrograms per day. And the gender of rearing, so these children, because they have their karyotype is XX, and they have Mullerian structures, they have high chance of having fertility as females. So they should be reared as females, and there may be gender identity issues later on, but as of now, we always prefer them to be raised as females.
And the big message, I think, from here is that if you have a boy, apparent boy with bilateral cryptorchidism, we have seen patients who are missed. They are labeled as boy, and that can come with shock. That's what Dr. Verma is highlighting, very important. And 17-OHP levels, again, should not be done right at birth. Wait for some time, because then they can be falsely high.
So let's move to the another case, a day 3 child having parents concerned about the DSD, and examination showing this kind of genitalia. Patient having no gonads with Prader stage 4. So Dr. Purnima, what you will advise for this patient, and how you will proceed?
So with this picture, what I could say is there is virilization of the genitalia, wherein the clitoromegaly is into stage 4 of Prader, and there is also scrotalization of the labia. So the next step would be to see what is the clinical clues that I could get for the categorization of the DHD. So if there is any evidence of hyperpigmentation, the likely diagnosis would be congenital adrenal hyperplasia. And among them, the variant of the subset of the CH, if there is evidence of hypertension, then the likelihood will be 11-hydroxydeoxylase as well as 17-alpha-hydroxylase deficiency, which is usually seen in childhood, not in the newborn period. Salt wasting crisis is seen most commonly in 21-hydroxylase deficiency and also in P450 oxidoreductase deficiency, 3-beta HSD deficiency, as well as star and side chain cleavage and Smith-Lemli opiates. So skeletal dysplasias are predominantly seen in P450 oxidoreductase deficiency as well as SOX9. Mainly the limb deformities as well as joint contractures will be seen in the newborn period. And if there's any evidence of polydactyly and syndactyly, it is more a clue towards a Smith-Lemli obese syndrome. And with these, if we could get a prenatal history of any maternal virilization during the pregnancy, so the diagnosis or the clues would go towards aromatase deficiency and P450 oxidase deficiency as well as luteoma and the ovarian tumors. So one of the subcategories of the one of the subcategories of the antigen excess. So going back to the algorithm, and this newborn doesn't have, is there a palpable gonads?
No.
So there
no
are no
gonads.
palpable gonads. The next step would be to go ahead with the ultrasound pelvis and look for the gonads and whether the Mullerian structures were present. So Mullerian structures were present. Then the next step would be to look into the cytogenetic studies, and the cytogenetic studies revealed 46XX. So this tells us, coming into the category of DHD, 46XX DHD, are we looking at gonadal dysgenesis or the congenital adrenal hyperplasia? That is the inadequate, the deficiency in the synthesis of the sex steroids. So the most common is the CH. And among CH, 17-OH progesterone levels to be looked at. The most common condition that we come across is 21-hydroxylase. Being a newborn, difficult to differentiate from 11-beta hydroxylase, which can also present with salt wasting crisis. So deoxycortisol to be done. And 17-OH is 25 nanogram per ml, which is suggestive of congenital adrenal hyperplasia. The next step, we would like to look if there is any further blockage in the steroidogenic pathway. So maternal virilization gives us a clue for aromatase deficiency. So this is more suggestive of a aromatase deficiency in this newborn. So the key message.
What you will advise for gender of rearing in this patient?
So in this baby, gender of rearing would be female.
So what is the take-home message for this patient, Dr. Punima?
So the take-home message here is the presence of Mullerian structures with no evidence of palpable gonads as well as cytogenetic studies revealing XX, 46XS, and with the evidence of maternal virilization, which is strongly pointing towards aromatase deficiency, is more a clue. The aromatase maternal virilization gives us a clue that it is due to aromatase deficiency.
I think that was a very, very interesting case, and the reason we brought it here was there was one more finding we had in history, that the penile size did not increase after birth, because whenever you have CH or something, the phallic size increases because of the mini puberty, or CH, of course, they will increase. But here there was not increase, which basically meant that as the androgen exposure was less, estrogen production was also, where the estrogen production was less, androgen was also less. And very carefully, when we asked, we got that history of some virilization in the mother, which was not very significant. So again, always go deep in terms of asking for history, because that can avoid unnecessary workup for in the form of steroidogenic other factors like gonadogenesis or other things.
Let's move to another case. A 14-day-old child. Parents came with the concern regarding the DSD examination showing this kind of genitalia. Patient having bilateral palpable gonad is there, but in USG there is no uterus, and karyotype showing 46XY. What you will think about this patient?
Thank you, Dr. Manoj. So using this case scenario, I will like to again reinforce the importance of examining the gonads and the Mullerian structures in a case of DSD to further classify them into XY or XX DSD. So absence of Mullerian structures with gonads signifies that there was a functioning fetal testis which produced AMH, but there was an inefficient testosterone action. So this could either be due to a defective testosterone production or a final testosterone action. And using a combination of these hormone levels, DHEAS, androstenedione, testosterone, and DHT, we can further localize the level of defect in the adrenal steroidogenesis pathway. For example, if all four are low, then the defect lies higher up in the adrenal steroidogenic pathway, as we can see in the star defect. While if all these are high, then this classifies it into a receptor defect, which is seen in androgen insensitivity syndrome. So using these chemical bioparameters and the clinical pointers, could you please give me the findings of this case further?
There is
so as already described by you, there were palpable gonads while the Mullerian structures were absent. So to classify it into whether it was a testosterone production defect or an action defect, we need the testosterone levels. So what were the testosterone levels? So as these were low, it states it could be a testosterone production defect, an isolated testosterone production defect, or a combined adrenal and testosterone hormone production defect. So getting a sodium status in such cases helps us differentiate between the two pathways. So as you have already pointed out that there was hyponatremia, then clearly it was an adrenal involvement as well and not an isolated testicular biosynthetic defect. Further, you have given me the value of 17 OHP, which was moderately high. So among these four, 3-beta HSD is the one which can have a high 17 OHP with low sodium and the clinical picture of this patient.
What you will advise for gender of hearing for this patient?
So gender of hearing should be one thing which should not be done in an emergency. It should always be done after complete evaluation because the further sexuality and reproductive ability will depend on this. Also, the psychology of the child depends on the hormonal milieu. So for all 46XY DSD, except for androgen insensitivity syndrome, we recommend the gender of hearing to be as males. So from this case, we can again reinforce the message that absent Mullerian structures in presence of a gonad is 46XY DSD, and presence of salt wasting signifies that it is a combined adrenal testosterone biosynthetic defect along with a 17 OHP, high 17 OHP, which points towards a 3-beta hydroxysteroid pathway. And gender of rearing should be male in this case. Thank you.
Thank you. We have another case. A 14-day-old male old child came with the concern of the DSD examination showing asymmetrical genitalia. A right-sided testis is present, and on a USG uterus is also present. So, what do you will think about this patient?
Thank you, Dr. Manoj. This is definitely a case of DSD. If you see, because gonads are present as well as a Mullerian structure is present. If we recollect back, if we see the graph that's described before, if there is a gonad plus uterus, we have to think of two differentials, either a testicular DSD or a Mullerian hormone secretion defect. Okay, so let's go ahead and evaluate this case. So can you just highlight the karyotype of this child?
Yes.
So this karyotype looks like a 46XX. Okay, so this is a 46XX with Mullerian structures present with right gonadal gonads, right-sided gonadal testes, right?
Yes. So I think this was a very important thing to remember, that we actually asked for 50 plates, but this was given as 20 metaphyses only. So this is again a big message probably coming in surgery, that this could be a mosaic typically in that setting, because you have to have some Y line, which was there in this case.
Yes, or it can be an SRY insertion.
Yeah.
So considering the presentation, if you go through the flow chart, we can see that the child had palpable gonads. He had Mullerian structures present. So the two differentials that we had were either AMH synthesis defect or AMH resistance or a O testicular DSD. But with the clinical picture, the child looks most likely a O testicular DSD and a karyotype of 46XX with a mosaicism. Okay, so the take-home message from this case is that, as sir described previously, if there is a gonad plus a uterus, if it is present, it goes towards a over-testicular DSD. The child needs to be evaluated properly. And on examination, if you ever find that the child is having asymmetrical genitalia, it is most commonly suggestive of over-testicular DSD.
Let's move to the another case. We have 15-year-old girl presented with a delayed puberty. Patient having inguinal gonad is there with no Mullerian structure. Dr. Varuna, what you will advise for this patient, and how you will proceed for this patient?
So if this child has an inguinal gonad but no Mullerian structure and has not undergone puberty, then we are definitely dealing with an XY DSD, because the inguinal gonad, a palpable gonad, is highly suggestive that it is a testis, and no Mullerian structures confirm that there was a testicular tissue present during the intrauterine period that secreted AMH. So the next step would be to know whether this is a disorder of steroid synthesis or a disorder of steroid action. So now I would like to see what are the testosterone levels and what are the gonadotropin levels in this child.
FSH we did that was 120, and karyotype is 46 XY, and testosterone is very low, 0.1 nanogram per ml.
So definitely it is a steroid synthesis defect, that is testosterone is not being formed. Now if testosterone is not being formed, I would also like to know what is the status of the other hormones, whether they are being formed or not, and is there, what is the salt structure status of this child, whether she is salt wasting or she is hypertensive. So you've mentioned that this child he has a BP of 150 by 90, which is definitely high for a 15-year-old child, and potassium is also on the lower side. So this child fits into a deficiency, a 17 hydroxylase deficiency.
And what will be the key message for this patient?
So key message is that if you have a XY DSD or a girl with presenting with delayed puberty and hypertension and does not have has very high FSH levels, we should definitely consider a possibility of 17 hydroxylase deficiency. So primary amenorrhea may just be the presentation of DSD in some cases.
Okay. Thank you. We have a 12-year-old boy presented with the complaint of the hematuria. On examination, there is no palpable gonad. Dr. Punima, what you will proceed for this patient?
Can I have the algorithm, please?
Yeah.
So this is a 12-year-old boy with hematuria. He doesn't have palpable gonads. So next step, I would like to look at his ultrasound for gonads, and there is presence of uterus. So this is suggestive of androgen excess production. So I would like to look at the hormonal profile, the cytogenetics, and the cytogenetics reveals 46XX. So the clinical examination, the next step which I would like to look at is blood pressure, which is 160 by 110, which is hypertensive, and then the investigations to look for the electrolytes, which helps us to differentiate mainly from other variants of the congenital CAH. Hypokalemia and deoxycortisol is very high. So that is suggestive of 11-hydroxy dehydrogenase deficiency. 11-hydroxylase deficiency. So the gender of rearing for this boy would be male. The reason is he would have definitely had stage 5 Prader staging, where it is complete masculinization of the clitoromegaly. And that is the most severe form, and he must have been appeared like a phenotypical male. And the hematuria for this could have been the vaginal bleed. So due to urogenital sinus, presence of the urogenital sinus. So I would suggest for the multidisciplinary approach for this child, for this boy, with pediatric endocrinologist, pediatric surgeon for the genital reconstruction, as well as for the, not for the genital reconstruction, for the urogenital sinus correction, as well as the psychiatrist and the psychologist. Mainly, he will definitely have issues of gender dysphoria as well as the identity.
Thank you very much. A 15-year-old girl presented with the primary amenorrhea. Height is 154 centimeter. Weight is 48 centimeter, 48 kg. Breast stage 4 and pubic head 2 with inguinal gonads. Dr. Neha, how we will proceed for this patient?
So again, coming back to my previous message, in a case of DSD, we have to focus on the two structures, gonads and Mullerian structures. As you have said that there are palpable gonads, could you please tell me about the Mullerian structures, whether they were present or not?
Uterus is absent and karyotyping is 46XY.
So again, as in my previous case, there is gonad, but there is absence of Mullerian structure, which signifies that there was a functional fetal testicular tissue producing AMH, but the testis action was inefficient. So we would like to know whether there was testosterone production defect or an action defect. So as you have pointed out that testosterone level was high, that means it was not able to act on its receptor. Now further, we want to see whether this testosterone was not able to convert into its active metabolite or whether the active metabolite was unable to act on the receptor, for which we like to know the testo-DHT level. So as you have mentioned that these levels were low, so this goes towards a case of complete androgen insensitivity syndrome, which means that testo was able to get converted into its active form, but this active form was not able to act on the receptor, producing a picture of complete androgen insensitivity. So these patients, they develop feminization during puberty. As far as gender of rearing is concerned, all 46XY should be reared as males except for complete androgen insensitivity syndrome patients. So take home message from this case would again be presence of gonads with absent Mullerian structure, think of 46XY DSD. In a case of primary amenorrhea without puberty, think of androgen insensitivity syndrome, and there is a feminization tendency during puberty, and all these children should be reared as females. Thank you.
So let's move to the another case. A 10-year-old girl presented with the complaint of clitoral enlargement. Phallic length was 2.2 centimeter. Patient having bilateral gonad present. Dr. Sajili, what you will advise for this patient? How you will proceed?
Thank you, Dr. Manoj. So let's go by the algorithm. So we know that the child has a bilaterally palpable gonads. So we need to look at the uterine Mullerian structures. So in this case, as per the data, you can see that the uterus is absent and the karyotype is 46XY. So this is a child with a 46XY DSD. Okay. So there is increase in the phallic length at the age of 10 years in a girl who had gonads. This may be because of slight increase during the puberty in patients with 46XY. Okay, so let's do an evaluation. So in this child, you see the testosterone levels were normal. Okay, so further, as Dr. Neha described, we need to know whether it is a hormone conversion defect or it is a action defect. So let's see what was the dihydrotestosterone levels. So if you see the dihydrotestosterone levels were low, so it means that the testo is being produced, but it is not getting converted to an active hormone dihydrotestosterone. So this most likely suggests a defect in conversion, which is most commonly 5-alpha reductase 2 deficiency. So in these patients, you can see that in puberty, they may have increase in their phallic length and they may undergo enlargement of the penile length. So if you follow the algorithm, you can come to the diagnosis of 5-alpha reductase 2. And the gender of rearing in these patients is always males because there is virilization that will occur in puberty. Thank you, Dr. Manoj.
Very nice discussion by Dr. Sajili, and very clearly, if you look at two things, we have tried to do all the 12 cases have shown that if you looked at basically the uterus and the Mullerian structure, you would be able to identify the diagnosis immediately, and that will help out. I think this has been a wonderful session, and it has been really great that it's actually 10 o'clock right now. So we have just on time. That means all the speakers have really worked exactly in the time. And I have to thank all the panelists for this program, Dr. Varuna Vyas, Dr. Purnima, Dr. Neha, and Dr. Sajili for having this wonderful session. And thank also for Manoj for really coordinating this. And this has been really one of the most intriguing topics that you will discuss of, but all 5 of them have really gone through these 12 cases like it was a cakewalk. So I hope all of you would have got stimulated about how to approach DSD, evaluate, go scientifically, look at testis, look at Mullerian structure, then you will go forward from there. So I think this has been a wonderful day. It's a marathon presentation today. 4 hours of sessions have been going on, and we'll join again tomorrow. Tomorrow is more of an emergency. So today it was more like a sort of a slow progress. Tomorrow we'll talk more of calcium, glucose, electrolytes, and hypoglycemia, which will be very, very rapid. And very importantly, we're going to have a quiz, which again we'll just announce the finalists in case some people might have missed it. We will announce the results. So this time we uniquely had this quiz, which was really, really interesting, and a lot of people participated across country and across the globe as well. And we have got 6 winners who will be entering our final round. So this quiz, which happened yesterday, was participated by 120 people. And out of those 120 people from 12 countries, and as discussed, there was a huge issues which were there in terms of the competition level was very high. The finalists for the quiz, the top 3 positions are for Dr. Devadatta Das from Kolkata, Dr. Ramiz from Madurai Medical College, and Dr. Ahmad from BHU, all of them doing endocrine training. And we have got 3 more people, Dr. Sawar Agarwal from Raipur, very eminent pediatrician, doing very well in the quiz, Dr. Sanju Joseph from Kerala, and Dr. Arun. So tomorrow, you're going to have 4 very, very marathon sessions on calcium, electrolytes, DK, and hypoglycemia. And then we're going to have very wonderful quiz, and it's going to be very interesting. So all of you, please join us tomorrow exactly at 2 o'clock. And at this point of time, I'd like to thank today we had 16 panelists, and we had got 4 moderators. So it's already 20 people who are involved, and all of them have done the job wonderfully. We have just finished on time. Once again, thanks all of you for doing this. Thanks Dr. Varuna, Dr. Purnima, Dr. Neha, Dr. Sajili, and Dr. Manoj for this session. Thank you all for this regards. Thank you.
Thank you.
There might be a couple of questions. Pleasure. I think there are a couple of questions. We'll see. Thank you. I think that's pretty much it. We'll close at that, and we'll join tomorrow again at 2 o'clock. Thank you.